Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom Namo Buddhaya, greetings of welfare, peace be upon all us. Ladies and gentlemen, welcome to today's guest lecture. It is an honor to stand before you as we gather for today's event. First and foremost, let us express our praise and gratitude to the presence of Ida Sang Hyang Widiwasa, the Almighty God. And before we commence, I would like to extend our greetings to our esteemed teacher and our invited guest lecturer who have joined us in this wonderful moment. And before we start, we deeply appreciate the support of PT Dexa for their support on today's guest lecture. Today, we are going to hear an in-depth discussion from our guest lecturer, our visiting professors, Professor Dr. André van Zundert. Please join me in giving a heartfelt round of applause. And today's lecture will be divided into two sessions, a series of lecture and workshop. And all sessions will be moderated by our respected teacher, Dr. Arya Wangsa. And without any further delay, I would like to hand over the sessions to our moderator, Dr. Arya Wangsa.
Thank you. I would like to start for all offline. So let's start lecture of Come in. Okay. I would like to present a overview of our lecture. Maybe patient bagaimana? Hati-hati terhadap trimester 1 dan 2. Tapi kontraindikasi yang tersebut ada 3 ternyata. Ada efek prematur closure terhadap proses dari mana dengan transfernya ke human breast milk mereka 1% with just maternal dose for in human. Jadi bagaimana tentang pada IV single dose varicocele low, walaupun dia punya efek low transfer terhadap varicocele dan colpicocele walaupun efeknya pada breastfeeding sangat kecil, tetap kita mana ini ada guideline terhadap anestesi dan sedation in breastfeeding women tahun 2020. Analgesik seperti paracetamol, ibuprofen, termasuk di sini varicocele, pace in low level into milk and woman kan breastfeedingnya masih bisa digunakan pada ibu tapi tetap berhati-hati pada pasien-pasien atau terus yang low body weight dan prematur. Liver, hati-hati juga tetap ada risiko hepatocellular ini, jadi hati-hati pada pasien yang sedang existing liver problems. Next. Nah ini pada kalau kita klasifikasikan di child B sama child child itu dos 50% reduction itu cukup bijak kita gunakan, tapi pada should be appropriate. Next. Karena dengan renal toxicity-nya terhadap renal prostaglandin ini sifatnya dose dependent reduction in prostaglandin dan juga efek pada renal itu dan renal dia tetap pada pasien-pasien yang tetap curiga ya. Ini practice recommendation-nya di sini evaluasi kontraindikasi pertama apa saja problem-problem yang pasien kan nggak ada kontraindikasi, terus lihat pasiennya punya risiko nggak terhadap obat-obatan yang spesifik terhadap tox 2. Pilih dosis yang tepat, sesuaikan dosis berat usia, berat badan manusia juga. Kita juga monitor ketat tanda vital, fungsi organ dan tanda-tanda durasinya sebisa mungkin kita berikan secara singkat dengan dosis efektif yang terakhir. Rekomendasinya lebih kurang sama dengan yang tadi. Varicocele harus digunakan hati-hati pada beberapa populasi spesifik seperti obstetrik, geriatri, dan orang-orang dengan masalah komorbiditas pada liver maupun renal. Sekian dan terima kasih. Waktu saya kembalikan kepada panitia. Oke, mungkin sekian ya untuk materi tentang varicocele-nya. Kita akan lanjutkan ke sesi selanjutnya. Saya akan kembali berbahasa Inggris. Welcome everyone to Anesthesia guest lecture today. Thank you for joining us, for all the attendants from the online and also the attendants that have a time to keep attending today offline in our class. So we are very discuss the topics for about Propofol Dosage Revisited in the Anesthesia Practice from guideline to practical very valuable insight from the lecture for today. For all time will be yours, Professor.
Thank you very much, ladies and gentlemen. It's too close, isn't it? Is it going? Thank you for coming today. It's a real pleasure to be here again. It's not the first time that I've been here. I think I've been here for 18 times already. So I know the place, and you see me over there somewhere. Yeah, and I've seen several of you growing up. Yeah, and Dr. Preva just told me, and he was here like you as a resident before, and now he is one of the senior staff. And obviously, I know Professor Made Viriana and Professor Chok, and I hope to see them later today as well. First of all, I would like to thank those who did all the work before. I mean, the invitations, the program outline. I see a beautiful banner over there. Thank you for producing all these things. And well, it's always a pleasure being here. Also, thank you for the technical support and for everything that you are doing for me and all the hospitality. I always feel very pleasant to come here. It is a real true honor. And I'm only here for 2 nights, so it's not that long. Yeah, so tomorrow night I will fly out again to Brisbane. And the reason is, well, they asked me to give quite a number of lectures. Last Saturday I gave a lecture for Jaipur in India. Last Friday, I gave a lecture for China. And a few days before, another lecture for China. You see, quite a number of things that I'm involved in. And in the program, I'm going to change one thing. I'm not going to talk about the videolaryngoscopy blades, but I'm going to replace it by another one, segmental thoracic spinal anesthesia, so that you can give anesthesia like this. Yeah? I think it's much more up to date, whereas with the videolaryngeal mask, with the videolaryngoscopy, that was the title. Yeah, we just have produced the new world guidelines on that topic. They will appear in a couple of weeks or months, I don't know, in the European Journal of Anesthesiology. So, and I thought maybe it's not the right time to do that at this particular moment, but I will do it next year. That is okay with you. Okay. Now, you immediately can hear I'm not a native English-speaking person. I was born in Belgium, in Europe, and Belgium is a tiny country. It's not sure whether it's as big as Bali, but maybe, I don't know. Yeah? But it's divided in 3 parts. The northern part that speaks English, the southern part that speaks French, and the eastern part that speaks German. So when I was at school, I had to learn first Flemish, then French, then German, and English came much later in my life. But I managed to lecture in the 4 languages. So I've given lectures in the 4 languages, yeah, in France and in Germany, and you name it. Yeah. But anyway, that's a little bit the history. Now, why you know that I'm now in Australia, in Brisbane, Australia. Remember, Brisbane is going to be not the next one, but the one after for the Olympic Games. So perhaps in 2032, you can come to Brisbane and enjoy the Olympic Games. Now, I was for a very long time a professor already in Belgium, in the Netherlands. I was an honorary professor at Yale University, Harvard University, Toronto University. So I've seen quite a bit of the world because they made me professors in so many places. I was always pleased that they announced me as a professor here at the Udayana University. And yeah, that gives me a pleasure to come here as well. And I think it has both ways some benefits. I mean, I can teach a little bit. I love teaching. My adagio is lifelong learning. You understand? And perhaps it may sound a little bit odd, but I acquired 36 diplomas, medical diplomas, because I strongly believe that a good teacher is also a good learner. Okay? So please don't give up. Once upon a time, long time ago, I was in the same situation as you are, and I had no idea I was going to stand here today. So, but you should see science and research and teaching. That is something that, yeah, that you need to do because you love to do it. You understand? It's not because you have to do it. It's a job. No. If it were a job, then I would never have achieved it. Yeah? But I produced 530 publications. Yeah? I produced 8 standard textbooks. You can all look that up on the internet. It's everywhere nowadays. Yeah? I was the promoter, supervisor of more than 50 PhD students. 10 of them already became a full professor. So, and that's my legacy. It's not about me. Legacy is about the future. You are the future. You are the next generation doctors, medical doctors. You are going to give the fire, yeah, and do that also with science. Yeah? Make sure that you are involved in science as little as possible. Maybe start doing an audit in your own department. Why are we doing something? Can we do it better? Can we improve it? That is what is science. That is what is medicine. Medicine in knowledge doubles every 70 days, 70, doubles. Nobody of us is capable of keeping up with all these knowledge. Yeah? So we need to refine it. We need to make sure that we understand a little bit. Yeah? That's my idea of wiki anesthesia, but I will take that as a topic next year. So today I'm going to talk first about Propofol. Propofol is used worldwide. Yeah. There it is. So Propofol, is that the point? No. This is the point. Propofol. We all are using Propofol during induction of anesthesia. And I made this presentation because in the United States, quite a number of anesthesiologists got legal cases because they were using too much. Too much, too little, just right. And that's not right. So I have not produced the articles as yet, it's still in my mind, but I have produced already some evidence that it is not correct to judge the performance of an anesthesiologist based on the use of Propofol because it gives you post-induction hypotension. Okay? Right? Okay, here is Propofol, and I want you to understand that you need to remember this formula, the hydroxyl group. We need that in my second lecture. Okay, so this is the Propofol we are using, and okay, and Propofol is used worldwide. When I was at your age, we had to use thiopental. Nowadays, everywhere we are using Propofol worldwide, and it's going up everywhere, in all countries, yeah, in the world. Okay, and sometimes we have misuse of Propofol. And I too have seen in our hospital in the Netherlands, where I worked for 30 years, yeah, and that's a very bad situation, that you as a professor of anesthesia, intensive care and pain therapy have to deal with suicides. And I was confronted with that as well. And even anesthesia nurses. One of these cases, they used propofol to place suicide on an operating theater. That should not be the case. And general anesthesia, we have lots of medication. Next one, please. We all administer anesthesia. We know how to do that with propofol. And I'm not going to detail how to give propofol. Yeah, but you see, we use lots of medications. This is the propofol. You see, propofol with that hydroxyl group. Very important to remember because I need that for my second lecture. Okay. So, propofol has been replaced. Sorry, propofol has been replaced with sodium. Replaced sodium thiopental, so pentothal, which we used in the past. Again, that was a very active, good drug, but in some situations, if you were using it too much, then you had big complications. It's one of the core medications in the World Health Organization essential medicine list. So it's very important, propofol. So it's one of those listed here. And propofol can be administered as a bolus, fractionated boluses, continuous infusion, or a part of total intravenous anesthesia or PCI strategies. And I'm sure you're using, but that's not a topic today. Okay? And we see there are several advantages, but there are also disadvantages. Significant hemodynamic effects, post-induction hypotension, intraoperative hypotension. That is what I'm going to talk about. Next slide. Yeah. Okay, so I'm not going to talk about the mechanisms of actions or about the pharmacokinetics, about common side effects. I'm going just to one complication, and that's both intraoperative hypotension and post-operative hypotension. Intraoperative hypotension. Okay, that is what I'm going to talk about. Next slide. Okay, so perioperative hypotension. That is the topic I'm going to talk about this today. And the causes, yeah, there are a number of causes and there are a number of remedies. One complication, and that's both intraoperative hypotension and post-hypotension. Okay. And what is intraoperative hypotension? A number of reasons. And I'm sure you have learned that all in your physiology and pathophysiology. You see that here in the carotid region, the sinus, the baroreceptors here. We have the adrenal region, the kidney nephron. So there are quite a number of compensations if we see that the blood pressure drops. Okay, what to do about it. Now, we need to be flexible with propofol. And you see the propofol doses in milligram per kilogram for adults, and that's listed in the FDA from the United States, you all know, and it's revised in August 2022. You see adults below 65, 2 to 2.5 milligram per kilograms of propofol. And if they are elderly, you give a little bit less, 1 to 1.5. In pediatrics, we use more. You see 2.5 to 3.5, and sometimes even 4 milligrams in the pediatrics. Pediatric babies, more than 3.5 milligrams per kilograms, and in 2 cases, very little. Neurosurgery, 1 to 2 milligrams per kilogram, and in cardiac surgery, I was involved myself as an anesthetist in cardiac anesthesia, and we never used propofol. We used etomidate. Can you use etomidate here? No? But anyway, etomidate is known for not causing post-induction hypotension. It's not everywhere available. That's the problem. Okay? But it says the dose of diprivan, propofol, to the patient should be titrated against the response of the patient. That's important. Yeah? So, suboptimal anesthesia induction and airway management. If you insert, for instance, a laryngeal mask airway, 50 to 80% of these laryngeal masks do not sit correctly if you use a blind technique. If you are going to use a vision-guided technique, nowadays we have these video laryngeal mask airways. This is very modern. There's a videoscope inserted in the laryngeal mask so that you actually can see how it sits inside into the hypopharynx of the patient. So checking the patency, correct placement, correct functionality, and correct sizing, but that costs time. So if you do a normal induction based on the FDA, the patient may wake up or react, and that's not good either. If the pharynx muscles start moving, then you can't insert a laryngeal mask. Or if you want to insert a tracheal tube, and the patient is starting to wake up, then you may end up traumatizing the vocal cords. That's not good. Okay, so you see, insertion was less successful after 1.5 milligram per kilogram with a failure of 50% of the patients. That's not good anesthesia. You understand? We need to provide adequate anesthesia and make sure that we can insert the right airway tool. If it is a laryngeal mask, if it's an endotracheal tube, but first you need to provide good anesthesia. That is what you need to do. And sometimes you need these additional propofol doses, small volumes. Every 30 seconds you give a little bit more. And that was required in 52% of the cases in this publication. So it is an unacceptable technique if more than 50% of our patients are not ready to get that airway. Understand? So this article, that in the Journal of Anesthesia and Clinical Pharmacology, they studied and they said 65% had with propofol optimal insertion conditions in 65%. That means 35% are still not optimal. Now, another article here from Tanaka and Nishikawa, you see propofol is given to patients up to 4 milligrams. That's much higher than the FDA estimate. You see the white circles and you see the black circles. Okay, the black circles, that means the patient is still moving during the insertion of the airway. The white circles, they are not moving anymore. But look at the concentration given, especially with the LMA. This is the COPA airway, this is an LMA. And you see up to 4 milligrams per kilogram are needed in certain patients. See that here? So it's an individual treatment. It's not that you can say, okay, it's 2 to 2.5 milligrams per kilogram. No, it's an individual treatment. And you have to judge what are you going to give to that particular patient. It's a clinical evaluation. It's not a theoretical one. That's what I want to stress, okay? Oh, sorry, this one here. So here you see, this is the COPA. It's also a sort of a supraglottic airway device, but not that widely used. And this is an LMA. And you see the dose, the effective dose is between 3 and 4 milligrams in this particular study. See that? So if we compare that in adults, 2 to 2.5 milligrams per kilogram, that's not good enough because they say 3 to 4 milligrams per kilogram in this study. Other one? You need to do it this way, maybe. Okay, so this is also an interesting study. This is from Schoenberg. Schoenberger is from the Yale Institute. Yale Institute in the United States. It's one of the top 5 institutions in the world. And what they did, they studied 350,000 patients from 36 institutions, all elderly patients, and they had 4 groups, 60 to 70, 70 to 75, 75 to 80, and 80 and over. Okay? And you see the doses they needed, propofol doses, it's not what they say in the FDA, 1 to 1.5 milligrams. No, it's more or less all the time much more. And it goes up even to 6 milligrams per kilogram. Don't immediately say, okay, I'm going to use all the time 6 milligrams per kilogram. No, what I want to say is use it and administer that what is needed by the patient. But the total induction dose in some of these cases was 6 milligrams per kilogram. But the majority was much higher than what was listed in the FDA. See that? It's much more. So what is it? 65% of the patients receive propofol induction doses above the typical prescribed geriatric doses, because these were all geriatric patients. Even in the 80 or older patients, they were using almost the same higher doses. You see that? So, and you can see with outliers 6 milligrams per kilogram. The elderly population doses is 4 milligrams per kilogram, and observed doses exceeded the typical dose range of a cohort of healthy patients 25 years younger, 40 years old. So the standard induction dose of propofol 2 to 3 milligrams per kilogram does not guarantee optimal insertion conditions, as almost, 38 to 60% of these patients have shown poor insertion conditions. That's not what we want. One. Okay. So guidelines are there for you. When you are young, you just start in anesthesia, then you need these guidelines. But guidelines are just recommendations. If you want, if you become a consultant, a senior anesthetist, if you become one of the senior persons in the department, then these guidelines no longer are really necessary, because you know how to do it. You have it in your fingers. Okay? At the beginning, you need guidelines. Guidelines are recommendations, but that does not mean they are put in stone. No, you can adjust it. If you see that the patient needs more, give the patient more. That is what is anesthesia. Anesthesia is a flexible. Yeah? We are not a rigid thing. It's not 1 + 1 is 2. No, that's not what we are doing. Anesthesia is much more flexible. And sometimes 1 + 1 is 3. You understand what I want to say? So we see, for instance, in the standard induction doses, in children a little bit more, healthy adults 1 to 3 milligrams per kilogram, with a rapid sequence induction a little bit more, in obese patients up to 3.5 milligrams per kilogram. These are the standard induction. Sometimes you need even to reduce the dose. That's what I mean by flexible. You need to adjust it whatever is needed to the patient. And if you see it's a very frail patient, then obviously you are not going to give that high dose. So frail patient, so ASA 3 or 4, you give maybe 1 milligram per kilogram or 1.5 milligram per kilogram. And then wait. If you see a cardiac compromised patient, you even go lower. And in neurosurgical case, 1 to 2 milligrams per kilogram. And if the patient in cardiac arrest, you don't use anything at all. You insert it because the patient will not react. But so we have standard induction doses, reduced induction dose, and increased induction dose. And what kind of patient need more? The person who is consuming alcohol. And I just looked up last night. For instance, on average, man in Australia drink about, 1 in 4 men in Australia drink about 10 units of alcohol per week or more. So that is what we consider chronic alcohol use. And then you have to give up to 4 milligrams per kilogram. And the reason is enzyme induction. And that increases propofol clearance. You know that. You drink a lot of alcohol, your liver is used to work much faster. It clears the clearance of alcohol much faster. So those who are on chronic sedatives, opioid, benzodiazepines, cannabis, you name it, it's an increased dose. So if you see in your preoperative visit that the patient on a regular basis taking benzodiazepine or anything that improves the liver function, then be careful, you need more propofol. Okay? Acute stimulants, cocaine, amphetamine, these patients, you need to give more. It will not be enough to give the standard dose. If a fit muscular adult, if I take some of you, I mean, 20-year-old muscular person, yeah, do you think it will be enough to use the standard propofol induction? I don't think so. You know this patient is going to use much more. And then obese patient, yeah, patient with obstructive sleep apnea, hyperthyroidism. So there are a number of diseases where you have to give more as well. And then variable dosing, for instance, ECT procedures, etc. So you need to be flexible. Guidelines are there, but they are not laws. You understand? The difference is a guideline is just a recommendation. A law, that's important. A law is, for instance, you need to monitor a patient who is under anesthesia. If you don't monitor a patient under anesthesia, that's a very tricky thing. Next, yeah. Okay, so just enough to do the job. Exact doses of propofol calculation. There's no method to an a priori calculation of the exact right propofol dose of each individual patient. It's a clinical judgment. There are no methods to do that. There's no such thing as an exact dosage of propofol used during induction of anesthesia. 75% of patients received an induction dosage of propofol above what is recommended by the official organ in the United States. And the authors even question whether the FDA needs to review its statement on propofol. And I hope by writing an article on this topic that the FDA will get the initiative to adjust their statement because it's not correct. Propofol needs to be administered in a sufficient dose. That's what I've told you. And 74% of the patients, even elderly patients, yeah, receive propofol dose above the FDA recommendation. And 46%, yeah, if aged over 80 years. So you can't have recommendation by an official institution like the FDA, and all the time we have to use more. That's not a good guideline, understand? So FDA guidelines are recommendations, not legally binding limits on drug doses. And propofol in the clinic induction varies across patients according to their condition and response. And propofol needs to be administered according to the situation. How? That is your evaluation. That is why you need to do a preoperative evaluation. Yeah? And that you need to measure blood pressure, heart rate, and you name it just before you start the induction. Propofol needs to administer so that there is no movement of the patient. Movement indicates underdosing. Movement may make intubation prone to severe complications. If you are putting in under trauma, under pressure, a tracheal tube, and the vocal cords are closed, that is not going to be a good result for that patient. That patient will have a sore throat, hoarseness, you name it, afterwards. That patient will not be thankful to you because he can't speak. There may be more serious consequences. Of course, we know that propofol can cause side effects. Intraoperative hypotension, post-induction hypotension, that occurs. And it occurs quite often. I'm going to show that in a number of cases. So we know it happens. But we all are educated and trained what to do with intraoperative hypotension. We know that we can give fluids. We know that we can give vasopressors. So that's not really an issue. I think we all can. Obviously, I agree we should try to avoid it as much as possible. But if that is possible, that's a big question. Okay? So priority number one is to realize an adequate airway. We know the ABC from trauma care. A, the airway comes first, then B, the breathing via the ventilator maybe, and then C, the circulation. So A, airway, B, breathing, C, circulation. That is the order. Okay? And obviously, in the circulation, we see the hypotension, but we know how to treat. All anesthetists are trained to cope with intraoperative hypotension and is resolved by administering extra fluids or vasopressor. So propofol uses intraoperative hypotension and desaturation should not be used in legal matters. They should not condemn you because you are using maybe a little bit more than the guidelines. Okay? On the other hand, you should not use less because also less is not. Okay, next one. The godly locks. Next one. So godly locks, that's about too much, too little, or just right. Okay, that's it. So the FDA provides general guidance, and Propofol in elderly patients should be 1 to 1.5 milligrams. These are recommendations, not legally binding limits. Explicitly recognize that the appropriate Propofol doses will vary across patients according to their condition and response. And so some older patients may need a little bit more than what you would think. Next one, please. Okay, so we have too little Propofol. That's not good because that can result in awareness, explicit recall, and that can result in mental issues. And if you are confronted with such a patient, that's a painful thing because the patient will say, I could hear what the surgeon was telling the assistant. I remember these things. I remember they were putting in a tube. I remember, but I could not react. I could not say anything. I could not move. You see? And if we then deny that these things were happening, the patient will start screaming everything. That's not good either. That can result in lifelong psychological issues. It has been demonstrated over and over again. That's not good. So underdosing, post-traumatic stress syndrome, and adverse mental health issues, lifelong. Movement during induction surgery may cause intubation difficulties and traumas. And reducing anesthetic doses is not risk-free. You need to understand that. And sometimes you need to say, okay, I'm going to use a little bit of a combination of different drugs so that I can reduce the incidence of post-induction hypertension, but at least that I can give sufficient anesthesia to the patient. Okay? Too much Propofol, that's an overdose. It's patient depending on the age, diseases, the ASH class, and post-induction hypertension is undesirable cardiorespiratory depression. And we all know that. And we all want to prevent these from because it can result in post-operative ischemic organs, especially if it lasts too long, longer hospital stay, morbidity, mortality. And so we need to carefully make sure that we take care of the induction. So the right dose of Propofol is just enough to do the job, no more than that, but no less than that. Okay? Titrated on physiological data and responses. Next, please. Yeah, so administer just enough to do the dose, to do the job. Next one. Okay, a few examples here. The appropriate dose. This is from a Chinese group in morbidly obese patients. The appropriate doses was between 2.3 and 3.5 milligrams per kilogram. Next one. Factors influencing the doses, the dose and speed of administration. If you just put it in like this, then you need much less, but don't do that. Just take a little bit time to administer it slowly. That's important. Pre-induction blood pressures, well, measure the blood pressure before you start an anesthetic. I think that's normal practice, isn't it? So a lower blood pressure before the induction, well, that may give you an alert. Please be careful, because if the blood pressure is already low, and I'm going to give medication that will even decrease the blood pressure further, then my blood pressure may be too low at all. Okay? Age, there are some association between age and post-induction hypertension. Females are more riskier to get post-induction hypertension than males, and give some fluids, vasopressors, and positioning. Elevation of the legs can help to return blood from the lower extremities to the heart. Okay, next. So you see here, Terwind, a very important article, the influence of anesthetic drug strategy on the incidence of post-induction hypertension. in non-cardiac surgery. Next. And you see over all the ASA groups, ASA 1, 2, 3, and 4, you see that pretty much that same doses. It's not that much difference. It doesn't mean that an 80-year-old can be, he hardly can walk, for instance, or he can run a marathon. Okay? There are differences. It doesn't mean age does not always mean anything. So we have here the black ones, the less than 65-year-olds, or the 65 years and old. Next one. So you see in that study of the wind, in summary, the drugstores, the doses, and the administration speed that have an impact on the incidence of post-induction hypertension. But the incidence is quite high. So in all your patients, and that is what I said at the beginning, perhaps you have to do an audit. Perhaps you have to look up how much is in that first 20 minutes post injection of your propofol. What is the incidence in this hospital? How you are doing? How often do you see post-induction hypertension? But you see in his study, 56% in the literature, 33% if you have a definition of a mean arterial pressure below 65 for 1 minute. But if you see a mean arterial pressure decrease of more than 30% from baseline for more than 1 minute, it's 40%. So you see, it depends on the definition. What is intraoperative hypertension? And the definition, I will show that in a moment, varies quite substantially. So there's no association between propofol dose and post-induction hypertension because it virtually occurs all the time. Neither low nor high propofol doses are associated with a difference in the incidence. And it's common sense that these anesthesiologists modify their propofol induction dose according to the patient needs. So no one size fits all for propofol dose. There is no such. It is depending on the patient's comorbidity and the ASA factor, the age, the level of frailty, debilitation, concomitant medications and pre-medication. If you have not given pre-medication, the patient may be more alert, more awake. While if you have given pre-medication, the patient may be partial asleep already. Surgical urgency, invasiveness, pre-operative, pre-induction hemodynamics, use of adjuncts, opioids, benzos, neuromuscular block. An elderly and debilitated patient may exhibit exaggerated hemodynamic and respiratory sensitivity to the standard induction dose. But we all know that. So flexibility, that is what we need. Next one. So this is a study from Thompson. What they did, they took every action to prevent post-induction hypotension from occurring. Understand? They did everything. And things that they can't do is unmodifiable risk factor, that's age, gender, the ASA, the comorbidities, low baseline blood volume, emergency situation, and some medication. You can't change that. That is the patient. Okay? And modifiable risk factors, that's the anesthetic drugs. That's what we are going to do. Induced vasodilatation, and whether we are using vasopressor, fluids, blood, you name it. So what they were doing in this study, they put in an arterial line in all their patients they were going to study. And they put up an alarm for hypotension if the blood pressure was below 75 millimeters as a mean arterial pressure. That's quite high. So they were alerted when it was 75 millimeters of mercury. And they started norepinephrine infusion when the mean arterial pressure was 70. I think that's quite high. We're going to do that in our cases, and I think quite a number of patients need vasopressor therapy, isn't it? And they gave an induction dose of very little, 55 or younger, 1.5 milligram per kilogram, and if they were older than 55, 1 milligram per kilogram. I would say this is very risky because many will not have enough anesthetic. But anyway, that's what they did. post-induction hypotension occurred in 51 of these patients. So even with all the measures that you can take, it still occurs quite often, more than half. And more than half at least one reading of a mean arterial pressure below 65 millimeters, despite all these efforts. So do you agree with me that post-induction hypotension is part of our anesthetics? We can't avoid it. It just happens. Okay? And don't forget the use of norepinephrine or any vasopressor that also has risk. Overtreatment, hypertension, acute kidney injury, ischemia, increased risk of blood clots, and then anxiety, headache, chest pain, pulmonary edema, bradycardia, hyperglycemia, and difficulty in breathing. So there are a number of disadvantages. Okay. Now, post-induction hypotension criteria are not uniform. We cannot predict which surgical patient will develop it after induction of anesthesia. Blood pressure, either high or low, is not a critical factor in the development of post-induction hypotension. It occurs quite often. And you look at these definitions, look at the criteria when you are going to label it as post-induction hypertension. The fact that there are so many criteria tells me it's not very easy to do that. Next one. Yeah. So here, this is another article from the group of Park here. What did they do? They looked at the definition of post-induction hypotension, and they see, for instance, sustained mean arterial pressure below 65. That was their definition, within 20 minutes since the injection of your Propofol. Okay? And they developed a machine learning, so artificial intelligence, to predict post-induction hypotension. Okay? Now they are using the very clever techniques. You all are aware of artificial intelligence. And look, all these factors we are looking at. And you see Propofol, very minor impact. Yeah? There are much more things, and I have to look it up myself, but for instance, the diastolic blood pressure, or the mean arterial pressure, you name it. There are a number of things in their artificial intelligence, deep learning system. Yeah? And it's not, the main thing is not Propofol. See that? So Propofol is not a really important factor. It's the whole concept of the patient. They are finger pointing, they are using blame culture, where that's not correct. They should not do that. Okay? So the occurrence of hypotension occurs, the incidence is 72% with remimazolam, another modern induction, or with Propofol. And it's identical. And they always told us, if we use a sort of benzodiazepine, that the incidence of post-induction hypotension is much less. No, they proved it's identical. Next one. So the definition of intraoperative hypotension, very interesting. Now, these authors, they studied 4 journals, and they found that there are 140 definitions of intraoperative hypotension. If there are 140 different definitions of hypotension, then I think it's not fair that estimating the post-induction hypotension on just one hemodynamic parameter may be not appropriate for every patient. Okay, next one. Okay, you see here post-induction hypotension and early intraoperative hypotension. And the only factor that's important is whether it's an emergency case. You see the odds ratio here. Yeah, emergency case, odds ratio here. Whether it's a spinal or an epidural. Very obviously, of course, male sex. Yeah, and the ASA class 4. Next one. Again, in this study from Emond, there's no association between post-induction hypotension and, for instance, 2-day in-hospital mortality or increased hospital length of stay. Next. Sure. Yeah. in 2018 in non-cardiac surgery. They used 2.5 milligram propofol, and the incidence was 36% of post-induction hypertension. Next. And again, a study by Green, and an incidence of post-induction hypertension of 60%, and another 44%. So a universally accepted definition of post-induction hypertension does not occur. How can you blame an anesthetist if there's no agreement worldwide? What does it mean, post-induction? Next one. Yeah. So 4 selected journals. And I read them: British Journal of Anesthesia, Anesthesiology, Anesthesia, Anesthesia, Analgesia. You agree with me? These are very prominent journals in anesthesia. And there are 140 different, where was it? Oh yeah, 140 different definitions of intraoperative hypotension. That doesn't work. So too many inconsistencies. And the problem of intraoperative hypertension should be approached as a dynamic phenomenon depending on various factors rather than dichotomizing blood pressure based on arbitrarily chosen threshold. Next. Okay, so there's no consensus. And this is the Biker study, a very important study here. No consensus on the correct definition, and there are at least, and they were using in their study, 50 different definitions, and they studied the mortality within 1 year following general anesthesia using propofol, yeah, and vascular surgery, and the incidence was 5.2%. And they studied intraoperative hypertension as a predictor of 1 year mortality. But there was no causal relationship between intraoperative hypertension and 1 year mortality. So even if you give a little bit too much, that's what we are doing. It is impossible that we know beforehand, this is the amount I'm going to give to this particular patient, and that should be enough to do the job. No, we always give a little bit too much, because we want to be on the safe side. But that does not mean that there's a relationship with that intraoperative hypertension and 1 year mortality. The outcome will not be determined by that intraoperative hypertension. The outcome of the patient will be determined by a huge number of factors, but not by that temporary drop in the blood pressure. The duration of low blood pressure is equally important in the possible association of intraoperative hypertension with adverse outcomes. Next one. Cessla, very important name in the anesthesia literature, checked 110,000 hours of anesthesia and post-induction anesthesia. 69% of the patients got post-induction hypertension with at least 4 minutes. That is what I want to say. It occurs quite often, but you need to take action, you need to give fluids, you need to give blood, or you need to give vasopressin. You need to take action. Don't let it happen too long. Okay? Although in some cases, I'm not sure whether you still are doing that, but we call that permissive hypertension. See that? Permissive hypertension, the surgeon is asking you, can you drop the blood pressure so that I have less blood loss? Does that happen here? It happened when I was a junior doctor. Yeah, that plastic surgery, big operation. They said, lower the blood pressure so that I have less blood loss. There's a whole discussion on that topic. Yes? But anyway, a mean arterial blood pressure below 65 mmHg was not associated with the composite complication outcome of any postoperative case. You see that? There's no relationship. And that's for 110,000 hours of anesthetics. No relationship whatsoever. Avoiding hypotension, obviously that's a worthy clinical goal and we need to do something about it. But it does not appear to be a useful metric of performance of the anesthetist. So anesthetist performance should not be evaluated based on intraoperative hypertension. The amount of intraoperative hypertension or post-induction hypertension is not a reliable measure of clinical performance, and it would be unreasonable to hold clinicians to a metric that varies so often over a range that it is not even associated with improved patient outcome. Next one. You see Shah, You see the duration of post-induction hypotension. And obviously we should avoid these categories. If it occurs at the beginning, yes, but you need to take action to avoid these. Okay? So they studied 22,000 patients, ASA 3 to 4, with, as a definition, mean arterial pressure below 65 millimeters mercury for at least 1 minute. And the incidence was 88% of our patients. That's a lot, isn't it? Yeah. Whereas Bleicher at 65 and another one 93%. Anesthesiologists are aware of the evidence of post-induction hypotension, but accept these to prevent other potential adverse effects such as awareness, hypertension, and the administration of vasopressor. Because if we give not enough, then we have all kinds of side. Yeah, and you do not want to see an insertion of a tube and the blood pressure raises to 250 over 130, for instance. Yeah, that can cause a stroke. Don't do that. Next one. So the impact of these different definitions, and there was an editorial referencing a decrease in the systolic blood pressure of more than 10%. You see that in 99% of all your cases. A decrease in the systolic blood pressure below 70, you see it in 5%. So if you want to defend yourself, it all depends on which definition you're going to use. Okay? So a lack of standard definitions makes it impossible to compare outcomes amongst different institutions. And the definitions of this post-induction hypotension drive the frequency and severity of the outcomes of anesthesia. Widely disparate definitions of post-induction hypotension are used, but we can't compare. So medical legal experts often exploit post-induction hypertension with or without intent to lead juries to potentially inappropriate conclusions. And I hope it is not going to work here in Bali or Indonesia. No anesthesiologist is blamed or even condemned and get a legal case for such a silly thing. It's amazing to review summaries of court procedures in which anesthesiologists have been accused of providing negligent care. That is what the outcome is. Nearly all patients develop intraoperative hypotension in anesthesia, and call for collaboration across the globe to develop a consensus how we define a common postoperative event. That is what we need. Next one. So, if mean arterial pressure is that an appropriate indicator of the quality of anesthesia care, we definitely need to say no. But blood pressure constitutes hypotension. There's no lack of consensus. And anesthesia quality care is much more than just a blood pressure. Conclusion: it is not possible to accurately predict hypotension. The authors question whether this blood pressure during anesthesia is appropriate quality indicator. Yeah? It may be sufficient for ensuring cerebral autoregulation, but we know there's a cerebral autoregulation in your brain. It's not really dependent on your blood pressure. So if it lasts more than 50 minutes, then you may say, okay, the anesthesiologist should do a better job. Okay? A single threshold for defining hypotension based on population averages fails to precisely identify what mean arterial pressure for an individual patient compromises organ perfusion. And major postoperative complications and mortality are more depending on patient, surgeon, institutional characteristics than the individual anesthesiologist. It's far too often just to use a finger point and blame technique and say, you have done this wrong. Whereas they should see the whole situation. Yeah? And the institution should help you instead of blaming you. Okay, next one. So, and this is the ultimate one, post-induction hypotension. We all know if you are going to give a spinal or an epidural for a cesarean section, we all see post-induction hypotension. Yeah? And this is from Cynthia Wong, one of the most important professors in obstetric anesthesia in the world. And the incidence in her system is 100%. All patients get post-induction. Next one. So this is a summary. Desaturation under anesthesia occurs. You see In 95,000 cases, you see the incidence is 27%. And it depends on how you define it. Saturation below 90 for 2 minutes or below 85% for 2 minutes. You see the percentage. Desaturation at night. Do you ever measure your saturation at night? There are now modern watches. You know these watches? They can tell you how much deep sleep you have, how much REM sleep you have, how much light sleep, I'm not 100% sure, light sleep, etc. Yeah? But they also give you the desaturation. And you see, it's very interesting. Desaturation in non-obese patients, the mean is 93.7% if we are asleep. I mean, you as young, healthy people, if you are asleep, your mean saturation is 93%, and the lowest at night is 78%. So we all have drops in our saturation. But if you are an obese patient, then the mean is only 88%, and the lowest goes as far as 68%. So it's a substantial decrease. Now, if any legal case, they would say, okay, 68% of your desaturation, and you were not treating it, and they would blame you immediately. And that's not fair. It's occurring. This is just in normal patient. There's nothing, not anesthesia related. And the intraoperative hypotension, I'm not going into deep in that, but you see all the list of these incidences and all these publications with 140 different definitions. It is impossible that you can blame an anesthetist, and especially if his performance related to post-induction hypertension. That is what I want to say. So the largest study, 350,000 patients, yeah, and they found an incidence of 65% received above the normal. So just enough to give the job. Next one. And the conclusions. Propofol dosage is an individual assessment by the anesthetist. It can vary depending on the situation, the patient's need, the surgeon, and the airway devices used. Post-induction hypotension, 140 definition, is a common occurrence in nearly all patients, and it is not possible to accurately predict hypotension following anesthesia. And the amount of post-induction hypotension or blood pressure management is not a reliable measure of clinical performance. A universally accepted definition does not exist as yet. And guidelines are recommendations. The individual anesthetist makes the final choice. And propofol doses should be used to evaluate, should not be used to evaluate an anesthesiologist's clinical performance. And in legal cases, post-induction hypotension is not negligent care by the anesthesiologist. And it would be unreasonable to hold clinicians to a metric that varies over a range that is not associated with improved patient health. Propofol dosing, not one size fits all. Thank you. I hope it helps you if for one day one of your colleagues has a legal case based on this method that you can defend it. Because it's not always patients that blame us for something. It is sometimes just colleagues who blame it. You were using too much of this, or you were using too much of that. Think a little bit more in a relevant space. It is sometimes we are in a situation and that we have to take instantly a diagnosis and a decision. And sometimes if you read it after, while you are reading it on the sofa, then it's much easier to say you should have done this or you should have done that. I just want to give with this presentation a little bit back up so that you feel more confident in what you are doing. Okay? And don't feel blame. I hate blame cultures. This should not be the case. We all can learn from our mistakes. We all can learn from things as presented here. You understand? But don't blame each other. We should be more united and help each other. And especially if there's an incident or a catastrophe. Please help each other. That is so important. Any questions?
Professor, maybe we should move to our second topic, maybe, and we will suffice for first and second topics. We'll start the discussion.
Sorry, I was not listening to it. Oh, okay, yeah, that's fine. Okay, next lecture.
Okay, thank you, our speaker. We should already topics, and then we should move to the second topics. Maybe.
Now, this is a completely new topic. The first one was also new, but I still have to write up the article. But this one is going to change your future. This one is improving anesthesia recovery. Sorry. Was it so bad? Okay. Okay. So this lecture is going to change your professional life. Okay? In the future. This is brand new. You will see why. So I'm going to talk about improving anesthesia recovery through patient-tailored biological neurocomputation in artificial brains. That's a very difficult topic, but it means discovering the working mechanisms of general anesthetics and reversal agents. Okay? So up till now, okay, do the next slide, please. This is Boston, 1846. In 1846, it was a revolution. The first anesthetic was given to a patient and the patient did not move again. And that was so fantastic. You see that? They could do an operation and you see that this is the dentist giving anesthesia. And that was fantastic. That was a revolution in medicine. The patient was asleep, no longer in pain, no memory, a true blessing. Next one. Next one. Okay. But for 180 years, we are wondering, how do these general anesthetics, how do they really work? Have you ever thought about this? You want to understand what you are doing. If you are administering medication, you want to know the physiology, the pharmacology, the pathophysiology, you name it. But for general anesthesia, next one, we still don't know it. Next one, please. Yeah. And I was always intrigued, how is it possible that we can administer drugs and that patients will become asleep just by administering sedatives and anesthetics? Very odd. Now, I was always intrigued by this and already did some studies in the 1990s, so 30 years and more ago. This is one of my PhD students, and I was a supervisor when I was at the University of Ghent in Belgium. Yeah? A supervisor promoter of a PhD thesis. And we were looking at, for instance, pharmacokinetics of inhaled anesthetics and carrier gases. Next one. But still, it was very difficult to understand these mechanisms. Next one. And we all know it has an impact. We know, especially in the elderly patient. And I'm sure some of your grandparents, for instance, elderly people undergoing anesthesia and post-operative, they lack memory loss. Is that correct? You've seen that in your family? Memory loss, brain fog, yeah? Post-operative delirium, post-operative cognitive decline. I think we all have seen that. And that's just after an anesthetic. So there must be something in the brain that is very important. Yeah? And especially these vulnerable patients, frail elderly patients, those with pre-existing neurological disorders, with dementia, for instance. Yeah? A patient with dementia, you have to give anesthesia. What is going to happen with their brain? Because you want to make them better, not worse. Next one. And this is the brain. This is the brain. Next one. And this is just one of these neurons. See an axon here, cell body, and all these dendrites. So we have about 100 billion neurons in our brain, 100 billion. And another 100 billion support cells, like glia cells. Glia cells. And they make connections over 100 trillion connections. Now, that is 12 nils. Very difficult to express it, but that's 100 trillion synaptic connections. What I'm going to do, I'm going to focus to one of these synapses. So my lecture will go just to one of these 100 trillion connections. Next one. You see here a neuron, and this is another neuron. Okay? So information is coming from one neuron to another neuron to another neuron, maybe 1,000 times, I don't know. Yeah. And eventually we see here, we call that in neurophysiology behavior. Okay? What is behavior? That is that we can use all our muscles. Use my muscle, I can move. Yeah? I can use all my senses. I can see, I can hear, I can talk, I can feel, you name it. That's my senses. And I can use all my organs. Okay? It's all depending on that one system from one neuron. So information from one neuron is going to the next neuron. That goes on and on and on and on, 1,000 times in a split of a second. Yeah, because if I want to use my arm, I should not wait too long. Yeah, it needs to go very fast. Now you need to understand this is very important. So information from one neuron needs to go to the next neuron, and then we have that behavior, muscles, senses, organs. Okay, please keep that in mind. Next one. And this is Professor Sudhoff from Stanford University, and he got the Nobel Prize of Physiology and Medicine in 2030. You see, this is Oslo. Oslo, the fantastic, beautiful aula. You see here the royal family, and he is giving the lecture here. It's beautiful. I have a full recording of this lecture. Next one. And he got the Nobel Prize. You see here, this is one neuron giving the information to the next neuron by these transmitters into the synapse. You all know that system, okay? And what he has done, he focused on the calcium. You see that, the calcium, and you see here one neuron and another neuron and all these vesicles. I only have put in, what is it, 2, 4, 5, 6 of these vesicles, but you can see there are maybe hundreds of them in one of these neurons, and that's to the next neuron. And he was focusing on that calcium mechanism. And calcium is one of these electrolytes that's very important, yeah, in that transfer from information from here to here. So they got the Nobel Prize. One. But then Sir John Eccles, he got a Nobel Prize in Physiology and Medicine in 1963. Next one. Yeah, for these GABA receptors. And GABA receptors are in the post-synapse, yeah, in the post-synaptic receptors. Okay, and this is, for instance, a GABA receptor with 2 alpha units, 2 beta units, 1 gamma units. And for instance, benzodiazepines are there, GABA, but also propofol, you name it, they have all kinds of spots. And this is, for instance, such a GABA receptor in that postsynaptic membrane. And this is a general anesthetic, propofol, or etomidate, or pentotal, or sevoflurane, yeah, isoflurane, you name it. You see, just that little thing here, and that blocks all the transmission, all the information is immediately blocked. Next one. So GABA australis, yeah, because he was an Australian, he got that in 1963. And that's what we see in the textbook, that we think anesthetics, general anesthetics, works on postsynaptic membranes here. The postsynaptic receptors here. GABA receptors, obviously there are a wide range of other receptors there. Yeah? Everybody thinks it's there. Yeah? So we have one Nobel Prize winner for this mechanism and another one for that mechanism. But it does not explain the working mechanism of general anesthetic. Because if we give stimulants, Well, they are not really waking up faster, these patients. If we make sure that the calcium mechanism is going faster, it does not really help us. Yeah? What we did something else. Next one. We looked at these neurons next. Yeah? And look, humans have about 100 billion. There's only one animal who has more neurons than a human being, and that's an elephant. The elephant has 250 billion of these neurons. Next one. Yeah. But it is very difficult to do studies on human brains while the patient is awake or asleep. I don't think it's very ethical. Yeah. But you can use Drosophila flies, and they only have, well, 100, 150,000 of these neurons. Or this is the roundworm, and they only have, what is it, 300 neurons. So it's easier to study 300 neurons than an organism with 100 billion neurons. Understand? Next one. Again, please do understand this mechanism. It's very important because I need it next. So what we are doing, we were not looking at the calcium here. We are not looking at the postsynaptic receptors, but we are looking at the presynaptic system. You do understand we have all these vesicles. These vesicles need to be transported in the direction of the presynapse membrane. But how does it work that this vesicle is going to merge with the membrane of the presynapse? That mechanism, that is so important. And that mechanism is very important because you see here syntaxin and other proteins, and that syntaxin protein needs to be transported in the direction of the vesicle. Next one. And that is syntaxin. So it's a protein. We need lots of these proteins to make sure that we can capture, that we can capture these vesicles and bring it towards that presynaptic membrane. Understand? Now that syntaxin protein is anchored in the presynaptic membrane. You see that red thing here? Okay, so it's anchored. It sits there. Yeah, but on the other hand, it has sticky Velcro-like parts so that it can attach the vesicle. You understand? So it's going to catch these vesicles and bring it towards the presynaptic membrane. That is what it is trying to do. But because this is so sticky, it needs a chaperone protein that sits on top of it. And I sit on top of it to prevent other proteins from misusing it, because this syntaxin needs to go all the way till these vesicles, and that is going to result in fusion, zippering, opening, so that the transmitters that is inside the vesicles are going in that synapse. Because these transmitters, that's brain talk, are going to give the information from that neuron to the next neuron, so that these transmitters now can work on GABA receptors and others. You understand? So it's that release mechanism. That is so important. Now, you see that chaperone protein sits on top of that. And what is anesthesia doing? General anesthesia is sitting just in between those two. And that paralyzes everything. So there's no transport anymore possible to the vesicle. And as a consequence, the patient falls asleep, cannot move anymore. None of these, remember the behavior that I told you, the muscles activity, the motor activities, the senses, all these organs, they are paralyzed because of our general anesthetics sitting in between those two. You see that here? So the general anesthesia drugs, propofol, pentothal, etomidate, volatile anesthetics like sevoflurane, they are sitting in between those two, and it does not move anymore. That causes anesthesia. Okay? So that is the mechanism. And I'm not going too deep into that, but you do understand. So we have also anchored proteins like this one, synaptotachmin, synaptobrivin, and they do the reverse. They sit here, and they are going to attach to that syntaxin. So it's rather complicated, but you do understand one is pulling that way, the other is pulling that way. Okay, next one. So this talk is very important. We call that brain talk. It's an essential part of all transmission of information from one neuron to another neuron. It is a mechanism that has not changed over millions of years, and I'm talking hundreds of millions of years. The dinosaurs had the same system. Yeah, birds had the same system. Reptiles, amphibians. What else do we have? Birds, fish, amphibians, reptiles, mammals, and humans. This mechanism is the same all over all species. It has not changed a single bit for hundreds of millions of years. And if there's a mutation here, you will not survive. So it's that basic. It's so important. If you have mutations here, you still can survive. If you have mutations here, you still can survive. And I will come to that in a moment, the mitochondria. Mitochondria give a lot of energy. And they need a lot of energy because this is a very fast process. Splits of seconds. Yeah. Okay? So, and the difference in brain size, whether it's an elephant, yeah, or a human being, or a reptile, or a bird, or whatever, or an insect, it doesn't matter. It has irrelevant to these general anesthetics. General anesthetics work everywhere. That's so good because thanks to that mechanism, now we can study on fruit flies or nematodes, roundworms, you name it, that same mechanism because it's the same as in human beings. That's so beautiful. Okay? So vital importance of mitochondrial energy, that's here. Neurotransmissions takes place in milliseconds. Most mutations are lethal. You cannot give it to the next generation. You understand? Yeah? Whereas quite a number of mutations do happen every day of our life. Even today, you will have some mutations, yeah, and you can pass it on to the next generation. But that's not the case with this one. And in later life, yeah, we see this here as a degeneration. It happens. Collapse of functional connectivity between one neuron to another neuron. And that results in Parkinson's disease, dementia, yeah, cognitive decline, postoperative delirium, memory loss, etc. So it's this mechanism. And thus far, we have no remedy. We have no treatment. But the more we understand, there's possibly an option in the future that we can find a remedy for this. So it's that important. So your generation is going to find out what we need to do. Okay? So this is the target mechanism for general anesthetics, but also for reversal agents. Because if the general anesthetics sits in between the syntaxin and the MUNC protein, the combination of the two, that is where general anesthetics are sitting, but also where reversal agents are. Next one. So again, it's that important. The motor skills, the senses, and the organs. Next. And look what's happening. For instance, if there's a mutation in your mitochondria, and I'm sure you know lots of other mitochondrial diseases, but specifically for this one. Next one. So this is the Lee syndrome. Not sure whether you have seen already a patient with the Lee syndrome, but this is a very unpleasant boy. He is unhappy all the time, but he can't hear, he can't speak, he can't see. Yeah? He sits in a wheelchair, he can't use. So remember the behavior, the motor skills, the senses, and the organs. Okay, next one. So I'm not going too deep into this one, but you see he has all kinds of problems, movement problems, retinopathy, optic atrophy, sensory hearing loss, constipation, hepatic dysfunction. So all these organs have dysfunction and they die when they are a couple of years old. Respiratory failure, cardiac dysfunction. Next one. And this is just one mutation in mitochondria. Now this is even worse. So this is a patient living about 20 kilometers north of Brisbane, where I work, and they have the Ohtahara syndrome. Remember that chaperone protein? You have the syntaxin protein with the chaperone on it, the MUNC protein, Now, the Munk protein is only covering it up for a while. It's not a very essential protein. And I told you in that whole mechanism, if there's a mutation, the patient will not survive. But this is just the chaperone protein. Now, in that chaperone protein, if there's a mutation, then you see the results here. This is Jack. Jack has hundreds of seizures every day of his life. He has the development of a newborn baby. He doesn't speak. He has hearing problems, vision impairment, sits in a wheelchair, can't move anything, and he will die when he's maybe 3 years old. You see how important this vital mechanism it is from brain talk, information providing from one neuron to another neuron. Next one. So nothing is working in Jack. Nothing. Okay? He has no future. He will not be able to pass it on to the next generation. So it stops with Jack. Next one. So that brain talk is so important. So that was a Munk protein sitting on top of the syntaxin, where general anesthetics are sitting in between. And it is that chaperone that allows the baby to be born, because it's a non-essential protein. If it were one of these ones, you will not even be born. Next one. No. So this is the Queensland Brain Institute, where we do a lot of this research. And I'm the overall supervisor here. This is one of the professors, Professor van Zundert. He's doing a lot of research on these animals. Next one. Yeah. And I see you have other professors working with me. Next one, you see lots of institutions are working together. Next one. And we do all kinds of animals, as you can see here. And a very simple thing. You take a bowel with a fish. Bowel with a fish. You do some local anesthetics, and all of a sudden the fish will tumble on the side. Okay? That is when it stops moving. You can do that with Propofol, with inhalation anesthetics, you name it. Very simple experiment, but if you add on then water or reduce the tank with the anesthetic, then the fish will start moving again. So very simple experiment, but we can do that with all kinds of insects and animals. Next one. You see that? So under the microscope, we have these roundworms. Remember, they have 300 neurons. Okay? We can study under the microscope, and we can look at the crowding effect. And I'm not going too deep in all the technical aspects, but you do understand we can see motor activities, we can study senses, and we can study organs. Next one. This is the Drosophila, the fruit fly. Fruit fly, see, it has about 140,000 neurons. Next one. And you see that this is the head with the facet eyes. And this is the electronic microscope. These are very expensive ones, millions of dollars just for one microscope. Yeah, but it can look directly into the brain of the animal. See that? And this is a special bowel. A special bowel, any movement that the fly is going to make will be registered. Okay. Next one. So we are using this mechanism. Next one. Yeah. So it's important that syntaxin covered with that Munk protein. Next one. And we were even, next one, we were even using, perhaps you have heard about the Great Barrier Reef. The Great Barrier Reef with all the corals and the fish, etc. In the north, eastern side of Australia, 2,000 kilometers long with all the coral reefs. And one of these coral reefs, we are using one of these corals to make it visible, because it's an artificial coloring of the whole system. So we actually can see it under the microscope because it's now colored. So you can measure it, but you also can see it. Next one. You see me doing it. Next one. So this is, for instance, rat cells. Next one. Or next one. You see, this is the fly cholinergic neuron. Next one. Now, experiments on humans, well, that's not very ethical. experiments on flies and rats, etc. Okay, you get permission from the ethics committee. But still, it's only a rat, or it's only a fly, or only a roundworm. But we can now use brain cells from humans. And how do we do that? So you see one of my PhD students here. Yeah, we are using brain organoids. Next one. So what we do, we take blood. You can take blood from anybody of you. We centrifuge it. We get plasma here and red blood cells and a buffy coat. Out of the buffy coat, we can stimulate that in many ways. And you see there's a whole procedure, not going too deep into that. It takes several months, and sometimes 7-8 months to produce it. But you see, we can produce stem cells. Out of this buffy coat, we can produce stem cells. And with the right stimulation, we nowadays can produce blood, bone, fat, tissue, muscle tissue, sex cells, immune cells, epithelial cells, and also neurons. That's fantastic. Next slide. Because now we can produce neurons. You see that even? We can produce an artificial human brain. Unbelievable, isn't it? And you even see 2 optic cups. It's not really an eye, but it is sensitive to light. That's the future. So now we are going to use this. This is very new. This is absolutely brand new. We are going to do now tests with our general anesthetics to understand what is going on on human brain neurons. Next phase is that we are testing reversal agents. I'll come to that in a moment. So these are brain organoids developing optic curves that respond to light. Next one. And you see that here there's a battery disc. You see a few of these organoids. And each organoid is 1 to 2 millimeters, and they contain each millions of neuron cells. You see how small it is. Next one. And we have set up this thesis and experiments. You see that these are the experiments done in this year, next year, and the year after. All kinds of experiments looking at the effects of propofol, isoflurane, sevoflurane, other general anesthetics, ketamine, dexmedetomidine, you name it. So we are doing lots and lots of experiments. And next one. And I told you, remember that you needed to have in that formula of propofol the hydroxyl group. Remember in my first lecture? The hydroxyl group, that is propofol. But if you put that hydroxyl group in the para position or the meta position, remember your organic chemistry, yeah? So if you put that in the para position of the meta position, you have analogs from propofol. And what they do, it depends on how much you are going to give, but it dislocates the general anesthetics from its position. So these analogs are going to take the place of the general anesthetics, and all of a sudden the patient awakens. Isn't that fantastic? And we have done something else. Instead of the hydroxyl group, we have changed it to a fluor group. Okay, same position. We call it now, instead of propofol, propofol. Propofluor, propofol. Okay, and it actually reverses. Next one. But we need to be careful, because by using, for instance, some of these things, and for that reason you need to do so many experiments, we instantly kill the animal. So we need to be very careful. Next one. So you see here, for instance, a fish experiment. You see, if you have in that bowel, you give the propofol, and you see the logarithm of the propofol doesn't matter, but you see the fish is not swimming. It's still. But if we give these reversal agents like propofluor, you see, depending on the dose, 5 micromole or 25 micromole, the fish wakes up immediately if you give that full dose. You see that? You see, this experiment tells us, okay, if we give propofol, the animal will go asleep. But if we give reversal agents, that animal can immediately wake up. So it actually proves that it is working. Next one. Okay, so we know propofol is working on the GABA receptor, it's working on kinesin, I'm not going into detail, well, and it's working on that presynaptic transmitter release machinery. Remember, syntaxing with the chaperone monk protein. See that? Okay. And what is propofol doing? For sure, it's not working on the GABA receptor or on the kinesin, but it's working on that neurotransmission in the presynaptic membrane, the presynaptic transmitter release machine. I think general anesthetic disproves general anesthetics work more in the presynaptic transmitter release machinery than in the postsynapse side. And we actually can wake up the animal, the patient, much faster. Next one. You see that? Propofol, propofluor, the fluor group here. This is normal situation if you administer propofol. So the activities of that behavior, I mean, the motor skills, the senses, and the organs, they decrease in functionality at least by half. It's not that everything stops. Yeah? But if you give propofol, depending on the concentration, they immediately can be reactivated and they wake up. Next one. I see. You see, this is all ongoing research, and many of my peers. Okay, working again. Sorry, I should not have touched that. Yeah. No. So it's a lot of research ongoing, and I have many PhD students or other researchers working for us. Yeah. Next one. On all kinds of topics. Next one. And I have these professors collaborating with me, and I'm the overall supervisor. Next one. So you see some of these researchers, and perhaps if you have the drive to do research yourself, you can be involved in this kind of thing. Obviously, we need very clever people who are very good at it. But I finally, you see, we are doing rodent neural cultures, human cortical organoids, patient-derived neurons, and ultimately, I hope I can be ready to use these things to test it also on human beings. That's my ultimate dream, obviously. Next one. So the search for general anesthetic reversal agent, it was a long time dream for more than 30 years ago, but it finally started to, next slide, it finally starts to provide some good results, I think. Can you do the next slide, please? Yeah. So we are looking at that behavior, whole brain dynamics, synapses, and single molecule dynamics. Next one. And we produce a lot of these publications. Next one. And this is, for instance, in anesthesiology last year, where we published Time to Wake Up, the ongoing research for general anesthetic reversal agent. You see, I'm working together with Harvard people as well. Next one. And I published in the Medical Journal of Australia. This is the most important journal in Australia. Recovery from general anesthesia, can anesthetic antidotes help? Next one. And this is, you will see it very soon because I've seen the proofs last week. So in anesthesia analgesia, presynaptic neurotransmission, a bottleneck to recovery from general anesthesia. Next one. And the whole thing has not gone unnoticed, both in Australia and outside of Australia. For instance, this is ANSCA. ANSCA is the Australian College of Australia and New Zealand College of Anesthetists. You see here the president, and they gave me next one, the highest award. Next one, please. They gave me the highest award, the ANSCA medal, for my contributions to the college and to improve medicine, etc. Next one. And they also gave me, this is all in the last year. I got, I think, about 12 awards just in the last year. Yeah. So this is a Australasian visitor. Next one. You know, I'm a Belgian, and the royal king, the King Philippe of Belgium, gave me the commander of the Order of the Crown in Belgium, which is very high esteem. That was in Canberra. This is the order. Next one. And this is at the university, the annual graduation ceremony in December last year. It was the 12th of December. And they gave me the highest diploma you can get. So you can get your medical diploma, master's, you have a PhD. There's one level above. That one level is a doctorate of medicine in research. And doctorate of medicine in research, they only award it for the whole university once every 2 to 3 years to one person who they consider to be like a leader, like a person who has given a lot of profile to the university. So that was very special. Next one. And then the college made me also the Professor Leonard Travers. And this is very special. So this is the Australian Medical Association. There are about 130,000 doctors, physicians in Australia. And they have chosen me for their highest award. This was just in August last year, for my contributions to medicine, healthcare, and a few other things I can't remember. Yeah? So that is very special. And this, I think it was the very first time they gave it to an anesthetist, an anesthesiologist. Usually all these kind of awards are given to non-anesthetists, to internal medicine, cardiologists, pulmonologists, endocrinologists, you name it. But this time it was to an anesthetist. Oh, okay, next one. And so, yeah, so it was also for my commitment to medicine, research, teaching, volunteering. Next one. And they gave me in Indonesia. The Indo-anesthesia meetings are very popular here in the southeast of Asia. They gave me their highest award. And I have to go to Oslo in 2 months' time, beginning of September, where they will give me the highest award in Europe for an anesthesia. You see, at least I've done a little bit that makes an impact, I guess. Next one. Yeah, amazing brain and brain talks are important. Next one. Now, the success of these things, so the clinical impact of that reversal agent, that we understand the mechanism, is enormous. Because you will be using these reversal agents, say, in 10 years from now. You first have to do these tests on human beings. But once they are, and they are so promising, and I almost can guarantee you that you will be using these things in the future. This is a new class of medicine. It does not exist as yet. And there are about 400 million patients undergoing major surgery and general anesthesia worldwide every year. So if we can help them, that's going to make an enormous difference. I mean, can you imagine if you have a theater list and you can give something as a reversal agent, the patient wakes up immediately. There's no need for you anymore to keep the patient in the operating room. You can bring him to recovery, and maybe recovery time can be. And they can go to the ward much faster, or they can go home much faster. That will have an enormous economical impact as well. So I think 400 million patients undergoing general anesthesia worldwide per year can have a faster recovery, and hopefully a much complete recovery without less impact. Right? No post-operative delirium, no post-operative decline. You understand? So improve patient outcome, faster recovery, less cognitive impact, yeah? Even for frailty patients. If we can prevent these memory loss from happening, or dementia, or whatever. Okay? An academic impact, well, you've seen if you understand this kind of thing, the physiology, the pathophysiology, yeah, that's important. It's important for new research methods, new theories, and a new class of medication. The citation of our work by other researchers, of course, one of my collaborators has about, I think, 30,000 citations already for his work. My citations are about 15,000, but he got it even 30,000. Society and community impact, public awareness, the change of public attitudes. They will expect you to use these reversal agents because they want to go home much faster. Understand? So policy impact, we have guidelines. We will change these guidelines. And we have health policies, protocols, hospital procedures. And these protocols will be used by governments, professional society, like your own professional society. And it has an economic impact. And I told you already, it will result in cost saving. And anything in healthcare that will result in cost saving, well, the Ministry of Health will be very happy with that. Understand? Next one. So we come 180 years ago. Recovery from general anesthesia was always a passive process. We could not accelerate. Next one. But nowadays, if we can see these patients 1 minute after their operation and they are awake like that, that is what would benefit. Okay, next one. So you see the first revolution was in 1846 with the discovery of general anesthesia. And I think we are at the front of the second revolution with the discovery of reversal agents against these general anesthesia. That's a novel class of drugs in medicine. For that reason, time to wake up. Next slide. Thank you very much, and I'm happy to answer any questions.
Thank you very much for Professor André van Zundert for the first and the second topics, very insightful for us. Maybe I'm gonna conclude a little bit to reminding the first topic and then also the second topics, and then we can move to the discussion session. Okay. Maybe for the first topic, I'm gonna use English and Bahasa also. In achieving for the optimal propofol dose, neither too much or too little, but just right. To find the right dose is essential for the safe, in the purpose of safe and effective anesthesia. There is no universal, like one size to fits all dosage. Instead, dosing using should be individualized based on the each patient unique characteristics, clinical context, and also physiological responses. The guidelines serve, and remember, the guidelines that been published by the FDA serve as a important recommendation. But remember, the clinical judgment is should be flexible and remain firm. For the first topics, mungkin untuk teman-teman mengingat untuk baik residen ataupun bagi dokter muda juga ya, untuk penggunaan dosis dari propofol itu sendiri tidak menggunakan untuk mencari dosis yang just right atau yang tepat sekali, tidak terlalu sedikit, tidak terlalu banyak. Tadi memang sudah ditampilkan bahwa sangat depend dari pasien itu sendiri, depend juga dengan kecepatan pemberian dan lain-lain. Tapi perlu diingat, memang harus di-individualize, harus dicocokkan dengan tipe pasien yang kita alami itu sendiri, kita hadapi itu sendiri. Kita lihat juga konteksnya terhadap klinis pasien, penyakit yang dia bawa sebelumnya, kondisi sebelumnya, dan juga respon-respon fisiologis yang terjadi setelah pemberian. Guideline yang ada itu hanya sebuah rekomendasi. Nah, untuk clinical judgment dan penggunaan dosis yang tepat itu sangat terus bersifat fleksibel dan dicocokkan dengan respon masing-masing. Untuk topik yang kedua, mungkin perlu diingat juga bahwa for the second topics, maybe thank you for enlightening the presentation and deepen our understanding about the biomolecular, about the brain talk of presynaptic membranes, highlighting the pivotal roles of release mechanism, about syntaxin, about the chaperone proteins. It's a very fresh insight for us to move beyond the traditional focus on our traditional focus about the calcium influx and also postsynaptic GABA receptors. The presynaptic membranes is very insightful for us. And then uh, exploring the analogy of propofol functional site without its direct effect opens exciting avenues for potential reversal agents and targeted therapy. Untuk teman-teman, ini memang insight baru untuk kita ya, bahwa propofol ini selama ini kan kita taunya reversal itu mungkin yang paling dekat adalah reversal dari benzodiazepin ya, seperti flumazenil gitu. Nah, tapi di sini sudah ada studi terbaru bahwa gimana sih melakukan reversal atau antidot dari propofol itu, ternyata sudah ada analognya yang sedang diteliti. Penelitiannya masih memang pada mungkin lebih banyak ke animal models, tapi itu jadi insight ke depannya, gimana clinical impact-nya ke depannya, efek terhadap ekonomi, terhadap pasien terutama, kita bisa mencapai mungkin for enhanced recovery after surgery juga cocok jadinya bahwa ada analog yang tidak menimbulkan efek seperti propofol, tapi bekerja untuk mempercepat reversal dari propofol. Mungkin sekian, maybe that's all for the first and the second topics. We move to the discussion session. Maybe thank you for the insightful lectures. And now let's turn our attention to discussion session. I will now open the floor for question and discussion. Maybe from the audience that came offline here, and also maybe for the all audience in the online from the Zoom and also from the YouTube, we can start discussion. You can raise your hand in here if you want, if you have any questions.
Was it easy to understand it? Yes, please.
Maybe from the audience. Give the mic.
Good morning, Professor André. First of all, thank you for the opportunity. My name is Tami, and I'm a medical student in my clinical rotation in anesthesiology here. I like to ask a few questions regarding to the first lecture. First of one is regarding on post-inductions hypotensions that you presented earlier. There hasn't been a single definitions universally regarding to PIH that you mentioned. So I'm going to ask about what is the mainly definitions that you hold on? Is it MAP under 65 on the durations of 15 minutes or 20 minutes? That is the first questions. And the second one is...
Let me first answer the first question. Otherwise I will forget them. Well, the definition used in my hospital is the mean arterial pressure below 65 millimeters. But there's also the point of the duration of that post-induction hypotension. And should it be 2 minutes, 5 minutes, 10 minutes? Look, I've seen cases where we had patients administered in my hospital with 15 minutes of hypotension. And sometimes the circumstances are like that you can't do anything else because it's such a bad case. Maybe it explains much more that this anesthetist is confronted with a very difficult case than about the performance of the anesthesia. Understand? So it's much more, the duration is very important. Anything that is below 2 minutes, disregard. Okay?
Thank you for the answer for the first questions. The second one is you explained earlier regarding to the PIH that the female patients have a higher risk developing PIH than male patients on the usage of propofol. Why is it? Is it something to do with the pharmacodynamics of the propofol, or is it something with hormonal influences? That is all. Thank you.
I think I can't give a right answer. The complexity of general anesthesia is very big. It's not just one. It is not just propofol. It is not just hypotension. It's the whole thing. We need to focus on the whole patient, not on just one thing. Because at the end, the patient will wake up. And what is important for the patient is that he fully recovers. What has happened in between that may have an impact for the surgeon, for the anesthetist, but it should not have an impact for the patient. So it's the post-operative recovery. The patient should fully recover. That is the duty of the anesthetist, that we help these patients to recovery, even if it is a very difficult situation with lots of desaturations, intraoperative hypotension, and problems for the surgeon, bleeding, you name it. All these incidents, catastrophes. But we, as an anesthesiologist, we are trained to do these difficult cases. We are trained to take care of a patient with problems of airways, circulations, breathing, kidney problems, liver problems, you name it. And it's a final outcome, the delivery of a patient in recovery or intensive care, with the highest possible outcome for that patient. That is important. So focusing just on one definition of hypertension, that's not what I want. That is, I hope that was one of the take-home messages. Just one definition is not good enough. It's just taking one thing out of a whole procedure. That's not correct.
Thank you for the answer, Professor. So I think the frailty of the patients and each of the portfolio of patients is more important than sex regarding to the developing of the PH.
If you fly from Bali to Jakarta, there's a straight flight, but you can do it via Kuala Lumpur. You can even do it via Australia. You understand? That is anesthesia. We have to work taking care of a patient in all kinds of circumstances. And for instance, 3 weeks ago, I was supposed to come here, but on the morning I was going to take my flight. There was a volcanic eruption in the eastern part of Indonesia, preventing from coming me. So we always have to work out the circumstances.
Thank you for the answer.
Prof, my name is Jonathan. I'm a second-year resident anesthesiology. I have a question. We have an old teaching that we have to stop ACE and ARB inhibitors because we have to. We are afraid of the post-induction hypotension. But last year, the European Society of Cardiologists they did a trial. And they compared between stopping, and continuing the ACE or ARB, and they did not find any difference on morbidity and mortality. And what about your clinical practice? Did you stop the ACE ARB or did you continue?
Well, this is just a perfect example how evolution is going on. What I learned when I was a trainee your age, and what we do nowadays is completely different. And that is what this research is doing all the time. If a study proves, and usually there are more than one of these studies proving the same thing, that these ACE inhibitors maybe do not make a difference, why should we stop them? I think we have seen it now with, what do you call it again, the Manjaro, the weight loss. There was a time, few years ago, when they said, okay, if you're on Manjaro or the GLP, I forgot the exact abbreviation, inhibitors, don't give anesthesia for the next 5 days. And nowadays they say, you just can carry on. You see, it's an evolution, and it's an evolution of knowledge. And if the knowledge proves that we can do in a better way, then we should do that. And I'm absolutely sure what you're doing in 2025 and what we will do in 20, 25 years from now will be different. But that's the evolution of medicine. That's where I say that knowledge in medicine is doubling every 70 days. In 1950, it took 50 years to double the knowledge. But that's nowadays with all the artificial intelligence, the deep learning possibilities. When you have a problem, what do? You take your mobile phone, you look it up, and you act. Okay? When I was your age, we had some books, very limited number. And we had to look it up. But that was always old information. Because whenever there's a book, and I produced myself 8 of them, it's outdated already the moment it is published. So what you are doing, using your information, looking it up on a mobile phone, that is the way forward. It's even better than going to your laptop, for instance. And your mobile phone, you have it in theater, you have it everywhere where you go and where the patient is. That's the way forward.
Thank you for the insight, Professor. There is a few questions in the online regarding the second topics. What do you think about the using of flumazenil or using the aminophylline
What?
or flumazenil and aminophylline like the reversal of benzodiazepine for the using of reversal of
Yeah. So what you're asking is whether we can use opioids. Yeah, sufentanil,
aminophylline.
aminophylline. Yeah. Now, aminophylline and other stimulants are working on the postsynaptic receptors. They are not really helping us to wake up the patient. So I'm not going to say it's not going to work in the future, but at this moment, I don't think it will really help. Because the fundamentals of all these research, they are focusing on the presynaptic transmitter release machinery and not so much on the postsynaptic receptor. We have a number, if you look it up in anesthesiology last year, my publication, there we explain it, how it works, all these stimuli on the postsynaptic receptors. Okay, but they don't really work.
This is quite novelty, like propofol.
Look, I never say no because I'm not 100% sure whether they really don't do anything. And not my research is not focusing on that.
What do you think about the using? Because all about using a propofol, like using setting the administration speed, like the dosage, it's still post-operative induction potential still happening. So, what about using the TCI, like
Yeah.
TCI, and adjusting the maximum infusion speed? What do you think?
Yeah. PIVA and TCI are good methods, and I think in the future they will be used much more, and for a number of reasons. We have inhalation anesthetics, and I was discussing with my driver this morning that all inhalation anesthetics have an impact on the greenhouse gas effect, on the environment, but also these are volatile. For that reason, we need to stop desflurane. Desflurane is the worst of all. But also isoflurane is not. And the best one is sevoflurane. It has the least impact. But it has still 100 times more impact than, for instance, propofol. But propofol has also its disadvantage. I can give a whole lecture on the impact on the environment and what we need to do to avoid it. So propofol should ideally be used more and more in the future as TIVA or a TCI. On the other hand, if you're doing that and avoid the bolus doses, then you also are going to use at least 500 milligrams an hour. 500 milligrams an hour, that is what you normally use with TIVA. Okay? So that's still a lot. Maybe it's like often it's a bit of everything. It's a combination of inhalation anesthetics, but not too much. Using propofol, but not too much. Yeah, it's like a good chef. You take all the ingredients to make a beautiful recipe. That is what you want to do.
What about to set in the TCI, like maybe when inserting the laryngeal mass airways, you have like recommendation or advice on your practice to set the concentration effect?
TIVA and TCI, especially TCI, came much later in my life. And so I was used to use bolus doses or fractionated bolus doses. Because I think it's that fractionated. That is what you need to have in your fingers. And I can recall, for instance, when I started epidurals in obstetrics for labor pain relief. We started with that very diluted solution, 0.1 to 5% in those days. And we were using bolus doses. And when I was doing my PhD thesis, that's now 40 years ago or longer, even my boss did not want me to use continuous infusion. Although I said, look, based on all the things that I read, I think the next step should be a continuous infusion. He refused me to do that in my thesis, but anyway, that was history. So, but the time has shown that we have now better continuous pump infusions. Yeah? And there's a lot of differences. Please be careful and know exactly which kind of continuous infusion pump that you are using, because it's very important. And over time, we have the models, the Mars, the Schneider, and now but that's from the late 90s. And nowadays we have the from Groningen. It's not Engelbert, but something like that. Yeah, and that is from a few years ago. So the March and the Schneider model was used for people with normal weights. Eleveld, that's Eleveld. But Eleveld now included new formula so that we can use it for normal, for obese patients. And you know that the average mean weight of a person in the world nowadays, 62 kilograms. 62. In Australia, the mean weight of a person is 87 kilograms. You cannot use these old models anymore. You need to use these new models. You understand? And I think 72% of Australians are either overweight or obese. You cannot use these old models to titrate propofol. So even for these continuous infusions technique, you need to make sure that you adapt the new models like the Eleveld.
Sir, maybe we should move to the third topics.
Okay. Yeah.
To the thoracic spinal anesthesia, right?
Yeah. Okay.
Let's appreciate giving applause to our professor. And then we move to our third topics. It's regarding the thoracic spinal anesthesia. It's quite, maybe it's very novel in Indonesia, especially. A few of my friends in here have learned to
Ladies and gentlemen, thank you very much for the kind invitation to lecture here at our Jaipur meeting.
I think in Lampung there's one center where they have been using it already 5,000 times. Okay, I'm going to talk about a new technique. A new technique which I developed, not 100% sure, about 25 years ago. It's a segmental thoracic spinal anesthesia technique. A segmental thoracic spinal anesthesia technique. I had a lot of experience in regional anesthesia. I mean, when I was a trainee in anesthesia, I did 1,000 epidurals in my first 2 years. 1,000.
Thank you very much.
I can't remember how many spinals, but at least 150 supraclavicular blocks in 1 year. So I was in a training center where they focused a lot on regional anesthesia. Later I found out that I could do, for instance,
in anesthesia. And these are
ganglion stellate blocks, sympathectomy. We were trained in celiac as well, in radiography.
Yeah. And they had an international training. You can see
moving anything. So. Okay. So 50 years ago, I started in anesthesia. Yeah, and these were 3 of my bosses: Dr. Vaas, Van Steenbergen, and Soetens. And they were trained internationally. Very, very unique in those days, but they were all trained in different countries. And my boss, who employed me in those days, said, I'm going to employ you for 2 years, but then I'm going to send you overseas to the United States and to UK. Yeah. And if you don't accept that, you are not welcome here. So he had already that idea that he said, look, if you want to be trained as a good anesthetist, you need to know, it's like a chef. You need to go to different places and pick up all the good things so that you can develop and become a better anesthetist. Okay? And that's what they did themselves. Next one. Not working.
Books.
Ah.
No.
Yeah, here it is. This one. So he studied international training for all of them. You see that Belgium, Sweden, Canada, Netherlands, you name it. Yeah, USA. and that combined information that brought a lot of experience and knowledge. You understand? If you have in your department people trained in different places, that is much better for the overall knowledge of your department. That is what he taught me. So I learned from this person what is general anesthesia, capnography. He was one of the first in capnography. A machine like this, 3 times the size of this catheter. See that? That was a normal capnogram in those days. He was one of the very first, and well, he taught me how to use that. Neurolab anesthesia, inhalation anesthesia, spinal anesthesia, and very extensive monitoring. They were really one of the most advanced centers where you could do your training. And he always said, look, I don't need you to do the anesthetic. We have enough staff, but I want to do it because thanks to the presence of a trainee, the other senior staff members are obliged to keep up with knowledge. Okay? That is how he said it. But we were trained and we were not allocated to one theater. For instance, you started the morning doing a plexus block, but not during the anesthetic or the maintenance of that anesthesia, because you were not learning that much anymore. So if there was another opportunity to do, for instance, an epidural, an abdominal operation, then you had to go to that particular station. You understand? So that was the reason that we had an enormous exposure to all kinds of technical things to do. So obstetric anesthesia, going back. Obstetric anesthesia, Professor van Steenbergen is one of the most esteemed people in obstetric anesthesia in the past. He founded the European Society of Freezer Anesthesia and Pain Therapy. He was the first Secretary General and later the President of the European Society. Now these meetings attract thousands and thousands of anesthesiologists. Yeah? They are the largest society. And in fact, well, later on, I also became the Secretary General. I became the second Secretary General, and later the 5th President or so, yeah, of the society. And this man, he really taught me the handy things. He was next to me when I had to do plexus block, epidurals, spinals. Yeah? He was there all the time. He was raised and trained in San Francisco, and with famous people in those days in obstetric anesthesia. So he also managed to do a pain clinic. So sympathectomy, celiac block, cannulus talar block, and we had to do, there was not an interventional radiologist in those days. We had to do that. Yeah? So we did, for instance, aortography. I don't think any one of you are trained in doing aortography, but we had to do it in those days. Yeah? Intravenous pyelography, so that you have to do these IVPs. So that was up to us. And I later learned to do facetal denervation, rhizotomy, and all kinds of pain blocks. And I established the Pain Society. Yeah? And I learned how to do cordotomy. Have you ever heard about the cordotomy? Anyone knows it? Yeah. In fact, a cordotomy is you go here in the spinal canal with a needle, yeah, and burn the fasciculus. And I don't have the images with me, but the spinal cord is divided in cervical region, thoracic region, lumbar region, sacral region. Okay? So, and in fact, when he got a tumor, he got a pancreas tumor at a certain point of time. Yeah? And I was no longer working in his department, I was working in the Netherlands. But I managed to do cordotomy. So if you have a tumor infiltrating your plexus here, it's a lot of pain. Day and night, non-stop pain, very, very intense pain. But if you do a cordotomy on the other side, because it's dislocation, yeah, cordotomy, you can take away the pain of one complete side. That is cordotomy. But yeah, you have to go into the spinal canal, yeah, and do the cordotomy. It's a very technical thing. Maybe it's a topic for the future, but you do understand. So they trusted me because after I was away from that institution for maybe 15 years or so, so they called me back to do that cordotomy on my own boss. Yeah, so they must have trusted me, I guess. So I established the Pain Society, and for instance, I started with a low dose, low concentration technique in epidurals in obstetrics. And in those days, I'm talking about 1980s, in those days in the United States, they were using for obstetrics in pain relief during childbirth 0.5% of bupivacaine, or for cesarean section 0.75%. And in the United Kingdom, they were using 0.25% bupivacaine. Now, the end result is that they were paralyzed, completely paralyzed. But if mishaps do occur, and instead of injections into the epidural space, and they ended up with toxic reactions because the catheter was inserted intravascularly, or in the subarachnoid space, intravascularly, that leads to toxic reaction. In the subarachnoid space, that leads to very high spinals or even total spinals. For that reason, in those days, in the early 80s, many patients died. Many patients in obstetrics died. That's just for a delivery or a cesarean section, because the doses they were using was far too much. And each and every journal, every issue of all anesthesia journals in those days was, how can we prevent these fatal accidents from happening? What is an ideal test dose so that we can see where we are? And I came up with a solution with the test dose, the ideal test dose. And I think it's on the next slide. Yeah, no, one,
So I
one
wrote this
before.
extensive.
Yeah, this one here. You see that every dose given in epidural anesthesia for vaginal delivery can be a test dose. I published that in anesthesiology. You see a number of these publications in anesthesiology to make it as safe as possible. Wherever you are injecting the local anesthetic, it should be a safe dose. For that reason, I came up with the idea, you never give more than a test dose. Okay? If you give a test dose, that's it. It should be effective in the epidural space. If you inject it into the subarachnoid space, it still should be effective. You can do a cesarean section because that's the extent of your block. But it should not be too much. It's not a very high spinal or a total spinal. And even if you inject it into intravascular space, normally causing toxicity and fatal reactions, this should not be the case. But I should be able to detect it. You can detect it because it gives you, depending on the formula, which consists of adrenaline. So you have bupivacaine plus adrenaline, and the adrenaline gives us the information that the location of the misplaced catheter is now in a vascular, intravenous location, and that gives you the tachycardia and the hypertension. You understand? So you can detect exactly where it is. Is it in the epidural space? Then it's effective. Is it in the intravascular space? Then you can detect it. and prevent you from administering more. If it is in the subarachnoid space, then you can prevent it, because it gives you the opportunity to a segmental spinal. Now, can you go one before? One before. Yeah, this one here. So, I learned the segmental thoracic spinal anesthesia, and I also was the founder of the diploma in regional anesthesia and pain medicine in Europe. It's now the most sought after diploma in the world of anesthesia. I learned from this man also airway management. And I started also about 25 years ago with videolaryngoscopy. I'm not going to talk about videolaryngoscopy today, but I was one of the proponents of videolaryngoscopy, and I introduced, for instance, videolaryngoscopy in Australia. But not only videolaryngoscopy, I also had the idea we need to do better, because for a tube, we want to see where it goes in. And each and every time, a vision-guided technique is much better than a blind insertion. If you have to do a blind insertion of a tracheal tube, you would not be happy. But with laryngeal mask, we do it all the time. And I thought, okay, if we use a video scope into the laryngeal mask, then we actually can see it. And I published that a number of years ago, 4 or 5 years ago, and manufacturers, at least 3 manufacturers, are producing now these video laryngeal masks. That's for another time. Okay? And I was always intrigued on this working mechanism. Now, these are, for instance, 2 of my 8 books that I produced. So this is the formula now used in most centers in obstetrics and in the world. So with a very low diluted concentration of local anesthetic. And this is when I was at Harvard University in Boston, United States, the Brigham and Women's Hospital, and we produced this pain relief and anesthesia in obstetrics. You see that with the professor of anesthesia in Harvard, and that was 1,100 pages. This was the first book in obstetrics and anesthesia. Next one. Just to give you a few more of these things. So this is another book I produced on regional anesthesia block, and this one is an atlas. And that atlas we produced about 5, 6, 7 years ago. I'm not 100% sure, but the first year it got 450,000 chapter downloads in 1 year. So you do understand the impact is much. Now, the European Society of Regional Anesthesia, I wrote an article 30 years strong. You see here one of the founders, as Albert van Steenbergen. That's his wife, and I was sitting in between them. And this is another president of that society. And this is the actual president of the society. Yeah, next one. You are going to give me that award.
I wrote an article on August Beer.
I wrote a few articles on August Beer. I'm not sure whether the name August Beer tells you anything, but he was the father of spinal anesthesia, but also of intravenous regional anesthesia. And I had to give a lecture. That was in Kiel, 100 years after spinal anesthesia. It's going very fast now. Sorry. Yeah. Okay. You see here, this is August Beer, early 1900s. He was married in 5. And this is during the wartime. He lived in, I think, in the region of Berlin or something. I forgot the exact name. It was occupied by the Russians in those days. Next one. You see August Beer here, he was doing a spinal, a patient in the lateral recumbent position. You see, not too fast, not too fast. Can you go back? Okay, you see August Beer with bare hands, putting in the spinal in those days. Yeah. Next one. Yeah, and they were using operating tables. You see, they were using all kinds of levels where they could do spinals. Next one. So on August 16, 1898, he did the first spinal anesthetics. And this was 100 years later. You see him lecturing here. And he was using something very special. In order to prevent spinal anesthesia going up too fast, they used this collar. You know that? This is a ruffle, an adjustable ruffle. And I happen to know the daughter. This is August Beer's daughter. And I was lecturing, it must have been in 1998. So I was lecturing during that centennial meeting on spinal anesthesia. And I happen to know the daughter. You see here, August Beer with his daughter, and that was in later life. And she was so happy that I was giving a lecture on her father. And she gave me all the information, even video clips and equipment and books from her father, so that I could write even more about him, I guess. Next one. Oh, no, this one. So he's the father of spinal anesthesia, 1898, and also of intravenous reso anesthesia. So he started giving these blocks, intravenous reso anesthesia block, in 1908. And I wrote an article just 100 years later, Centennial of Intravenous Reso Anesthesia Beer block, that was published in Reso Anesthesia and Pain Therapy. And I even was awarded by the American Society in New Orleans. So anesthesiology have every year their meetings, their annual meetings, and they gave me an award for this publication. Next one. You see here Thomas Ionesco, Professor Ionesco, doing all kinds of spinal blocks. See that in the cervical region, thoracic region, you name it. But look at the solution he was using. Have you ever heard about strychnine? Never heard about strychnine? Look it up later. Strychnine can be used to kill rats, for instance. They cause bleedings. Yeah. But look, that was his solution. Stovocaine, it's ametocaine, we are not using that anymore, but anyway, it was one of the early local anesthetics, to which they added some water and strychnine. You see that strychnine all the time. Unbelievable. If you would do that nowadays, they would take you immediately to court, I guess, because strychnine can kill people. Right? Next one. Okay, he described, so we are not talking early 1900, Professor Ionesco, 400 operations he did, operating on the skull, on the face, throat, thorax, upper limb, laparotomies, gynecologies, hernias, kidneys, urinary bladder, rectum, anus, and vaginal. So he was using it all the time. Okay, next one. So 1846, the first anesthetic with general anesthesia with ether, and the first spinal in 1998. Next one. Yeah, Ionesco here, August Beer. So you cannot imagine but how fast the information came from the United States to Europe or vice versa. You see here the evolution of reso anesthesia is going up very fast, with the first spinal, the first epidurals. Lidocaine became commercially available. Doppler ultrasound, bupivacaine was synthesized. The ultrasound introduction, you name it. Yeah, next one. And the combined spinal epidural technique, although I was the first to describe it, in fact, it was also used, but in a sort of difficult thing. For instance, Soresi used one needle and on different levels. Okay, I'm not, yeah. So, or two needles on two levels, yeah, and you see it. All kinds of different combinations. Next one. Yeah. So, in the combined spinal epidural technique, I was one of the founders with Professor Raval to do that, and had a lot of experience with that combined technique. Next one. And this is what we are doing. Segmental spinal anesthesia. So this is in the lumbar space. You see here the ligamentum flavum. This is the epidural space. You bring in a Dewey needle, and then a long, fine spinal needle goes into the subarachnoid space. So you can administer a minute amount of local anesthetic in the subarachnoid space, and if you want, you can increase your block injecting local anesthetic in the epidural space via the epidural catheter. That's the technique with a combined spinal epidural technique. And based on that, I thought, okay, if that is possible, perhaps I can use it also in the thoracic space. Okay, that was my logic in those days. And you see, this is in the thoracic space. You see the spinal cord. This is the epidural space. And in the subarachnoid space, there's still a lot of space. And I thought, okay, if we can do that, maybe we can use this combined technique, which is intended for a lumbar region. We can maybe use it now also in the thoracic region or elsewhere. Next one. Yeah. So, and we can use a lot of these combined, specifically designed new needles. You see that? So long Dewey needles through which you can introduce a long spinal needle. Okay, next one. All originally designed in the lumbar space, but now we can use them anywhere. Next one. So how to perform a thoracic spinal technique. I published that in the British Journal of Anesthesia almost 20 years ago. Next one. So what we do, you see here the Dewey needle in the epidural space and a long spinal needle in the subarachnoid space. Okay, so the long spinal needles in the subarachnoid space. Here you produce a very tiny amount of local anesthetic and a very limited spinal block. Okay, and you can use then the epidural catheter in the epidural space to extend the block if needed. Next one. And we take the advantages of both spinal and epidural anesthesia. Spinal anesthesia with a rapid onset of the block, a profound block, a reliable block, with using very minute amount of local anesthetic solution. And the epidurals, that is a titratable block, ability to prolong it indefinitely. You can go on days and days. And the longest epidural catheter, just one epidural catheter, I introduced in a patient for pain relief, chronic pain relief, and the patient died eventually of his cancer, was for over 3 years, one single catheter. It's possible. Flexibility, yeah, next. Yeah, and I produced, and this is in 2006, segmental spinal anesthesia for a case of a patient with very severe lung disease who had to undergo cholecystectomy. And this was a very difficult case. I was professor of anesthesia, intensive care and pain in the Netherlands, and 2 other institutions where this patient was presented, they said, 2 academic centers, they said, we can't do that. And I will explain you in a moment. Next one. So this patient's blood gas at rest was quite normal, yeah, but minimal activity. And minimal activity was just washing his face, resulted in respiratory acidosis. See that? Next one. And during the operation I did with that segmental thoracic spinal anesthesia, you see the Tiffinot index, that was 19%. Preoperative, 2 hours postoperative, it was 23%, and on day 3 it was 21%. So at least my technique was not interfering with the capabilities of his lung function. Next one. But it was for a gallbladder, laparoscopic cholecystectomy. Next one. Next one, yeah. So the patient, 47 years old, 78 kilograms, 181 centimeters, male, heavy smoker, COPD with a congenital disease. You see that here, an antitrypsin deficiency, etc. Okay. Frequently had respiratory infection, continuously was at home with oxygen, with severe functional impairment, and the lung transplant team was asked to do a lung transplantation. But during the checkup, they found gallstones. And the lung transplant surgeon said, I'm not going to do this operation on a patient with gallstones, because then immediately the lung will be infected and resect. I'm not going to do that. First, gallstones need to be removed. That means cholecystectomy before we will do the lung transplantation. Okay? And obviously, lung function severely obstructive patterns, and the patient was denied anesthesia because none of these anesthetists at 2 universities said, I'm not going to administer anesthesia to a patient. This patient is going to die if I give him general anesthesia. So they sent it to me because in those days I was the president of the European Society. They said, can't you find a solution for this patient? Because otherwise this patient is going to die. Next one. So I used the combined spinal epidural technique because I was very well trained in that kind of things. And I said, okay, I will do it on the thoracic 10-11 interspace here. And I know I have enough of space here. And I'm going to give a spinal block with this technique here, 1 milliliter of plain bupivacaine, 0.5%, to which I have added 0.5 milliliter of sufentanil, okay, 2.5 micrograms of sufentanil. It's not a lot. Usually you can't do an operation. And I put in an epidural catheter in the epidural space here, and the spinal block ended up with a sensory blockade of T3 till L2. See that? And there was no motor block. Next one. The patient was awake during the operation. I gave the patient 4 liters of oxygen, and the saturation was all the time 97%. Hemodynamics, yes, there was a drop in blood pressure, but that reacted immediately to ephedrine, you see, intraoperative hypotension. The heart rate dropped from 80 till 56, but then it was stable. Fluids given 1600, intra-abdominal pressure was 10 centimeters. I told the surgeon, please do a gentle operation and don't be too aggressive. I mean, intra-abdominal pressure of 10 centimeters of water, not 20 or 30 or so. Okay? No extra medication was given, no sedatives, no opiates. And at the end of the operation, I started the epidural catheter, 5 milliliters per hour, plain bupivacaine, with sufentanil. It was an uneventful recovery, no further deterioration of the pulmonary function, and the patient was discharged on day 4. And later, he underwent lung transplantation without any difficulty. Next one. Now, obviously, that raised questions for me and said, okay, do we know the anatomy of the spinal space? And in fact, we did not. So I wrote an article with one of my PhD students on this using functional MRIs. Next one. And you see, this is the spinal cord, the black one here. This is the head. This is the sacrum. And you see the spinal cord is positioned almost in the anterior region of the spinal canal. Anterior region, leaving a lot of space from the posterior side of the spinal canal to the posterior dura mater. See that? Much more than is the case in the lumbar region or in the sacral region. See the difference? So if we insert here a local anesthetic, okay, it will stay like that. Next slide, please. So here you see this is the local anesthetics. It's going up a little bit and going that way. But because of that curve of the spinal canal, it's restricted this. Okay, that is what I was doing. Next one. Okay, so laparoscopic cholecystectomy. But the thoracic, remember, nobody has done this before. And I was questioning, is this safe enough? I need to prove that if this is safe enough. Because I had anxieties. Okay, puncturing the dura mater in the thoracic region, what is going to happen if the needle is going to damage the spinal cord? I think that's a very legitimate question. And an extensive thoracic nerve block. What is going to happen if the block goes up far too high and the patient is not capable of breathing anymore because I'm interfering with the ventilatory space. But the diaphragm is unaffected and forceful expiration and coughing is also unaffected. Next one. So I described this anatomy. Next one. And as you can see in the next slide, so we did functional MRI studies. Now, in those days, functional MRIs were only done in Switzerland, not in Belgium, not in the Netherlands, not in France, not in Germany. So I had to go to do these studies in Switzerland. I took a team with me, PhD students, colleagues, even my son went with me, and we were doing these kind of functional MRI studies. So in all positions, standing, sitting, lying down, on the side, you name it. Next one. And I was even myself one of these volunteers. Okay, next one. And I'm not going into deep, but you do understand there are quite some differences. So we learned a lot about the anatomy of the whole spinal space from here all the way down. Next one. Yeah. And look here, in the thoracic region, you see here the spinal cord. We have the subarachnoid space. This is the dura mater, and this is the epidural space. This is, for instance, in the lumbar region, or even, so you only have these cauda equina here. See that? But they are very close to the epidural space. Here you see a real image. If you are going to do a puncture, you can hit one of these nerves, and that can cause you pain. Next one. So this is what I'm doing in the thoracic level. Next one. Yeah, this is lower down in the lumbar region where there's not that much space. Next one. Okay. And here you see overall there's a lot of space in the subarachnoid space. This is the epidural space. Okay, you see that? Okay. So in the thoracic space there is more space. Next one. Okay, so you see that here. Next one. Next. Okay, so this is thoracic region, lumbar region, caudal region. The spinal cord in red here, it's a lot of space in the subarachnoid space. This is the epidural space. Okay, but in the lumbar region, the spinal cord is positioned very close to the dorsal region. There's not that much space. Next one. Yeah, or in reality, you see that these are human cadavers. You see the spinal cord here in the anterior position, in the more posterior position, and this is the cauda equina, and this is the epidural space. Next one. So here again, this is a human cadaver, spinal cord, and this is the subarachnoid space. You see a lot of subarachnoid space. Obviously, this is a cadaver, it's not the real thing. Next one. Okay, what you do next, in the lumbar region, you bring in 2 needles almost perpendicular to the skin, whereas in the thoracic region, you have to put them in under a degree of 40 degrees because of the angulation, yeah, of these spinal processes. You see that? But that results in the subarachnoid space area of 4.5 millimeter, whereas if you go in an oblique way, it gives you a space of 8 millimeters, so much more. Next one. This is another thing, so in the lumbar region, this is in the thoracic region. Next one. Okay, so MRI studies reveal, see the spinal processes here. This is the epidural space. Yeah. This is the black one, that's the spinal cord, and this is the region behind the spinal cord and the dura mater posterior, so the subarachnoid space. You see there's quite a big distance. Next one. Okay, so you can measure that here, 4, 6, 8 millimeters deep. Next one. You can use these optimal angles to insert your needles. Next one. So we published that in 2008, the anatomy. Next one. And then we thought, okay, let's do a feasibility study. Is that only going to happen in one patient, that success, or is it going to be successful if we do a series of patients? So feasibility studies, we published that in the British Journal of Anesthesia in 2007. This is about segmental thoracic spinal anesthesia for a group of patients undergoing laparoscopic cholecystectomy. Yes. Next. Next. 20 elective patients using the CSE technique in the 10 thoracic interspace. First, a subarachnoid block, the same solution, 1 milliliter of plain bupivacaine and 2.5 micrograms of sufentanil, which is half a milliliter, and an epidural catheter. Next. What you see, this is the result. So the mean upper and lower sensory block was T3 till L3. So was this extent of block, but limited, leaving this part unaffected. And that's good, because if you do not block everything, if not the whole sympathetic chain is blocked, then at least you have some reactions to intraoperative hypotension, okay? Compensation mechanism. So by leaving this unaffected, there's that vasoconstriction in the lower extremities and the upper extremities. Next one. And you see here the hemodynamics, the blood pressure, this is 120. You cannot say that there was much intraoperative hypotension in these cases. See that? So this is systolic blood pressure, diastolic blood pressure, and this is the mean heart rate, around 60. Next one. And this is, I'm going to give you now a video presentation, how exactly I did it. So this is a patient, this is where I injected 10. And this is in fact the father of one of my orthopedic surgeons in our hospital. And I must say, this is the video. You can see how it's inserted. So I'm using the loss of resistance to air technique. You see the angle is 40 degrees to the skin. Then a long spinal needle is inserted. You actually can feel the dura mater. You only have to go just a little bit deeper. Yeah. Then you fix it with your needle. You see local anesthetic, cerebrospinal fluid is coming back. And you just add on the 1.5 milliliter of the local anesthetic. Okay. You slowly inject that. And once you have injected it, you can measure how deep it is. So it tells you how deep it is in the subarachnoid space. This tells you how deep it is in the before you reach the epidural space. And then you take out the long spinal needle and insert an epidural catheter. See, this is 15 centimeters, this is 20 centimeters. Okay, and this is a graduation, so you actually can see how deep it is into the subarachnoid space. Then you withdraw the Dewey needle, fix it to the back. Yeah, then the patient can turn on his back. Okay, see that? Now, the patient explained a little bit how he found the punctures. Then we are going to see what is the extent of the block. Okay. So now he reacts. So the upper level of the block is over there. Okay. The lower level. Stopped it, I guess. Yeah. And the lower level is around the knee. Yeah. So, but look. This is after a spinal anesthetic. Do you see a patient doing that with spinal anesthesia? Okay, and then he can watch his own operation on the monitor screen while the surgeons are busy. So he can watch his own operation here. Okay. So no sedatives are given to these patients. And look at the monitor screen, and you actually can see the blood pressure is normal, yeah, the respiratory rate is normal, saturation is normal, and heart rate is normal. Nothing is wrong. Okay, no, it's off. No sevoflurane, only oxygen, no nitrous oxide, and it was stable throughout the whole procedure. Okay. Now we are closing it, and the patient is now just after the operation, and we are testing it again. We are asking the patient, can you lift it? And he still can lift it immediately after surgery. See that? The other one. And the good thing is, now he can move himself unaided into his own bed. See that? You can't say it's too difficult. Huh? That's one of the surgeons. He's talking about with the patient. And you see he's quite awake. Okay, this is his son, the orthopedic surgeon. You see immediately in recovery, both are happy, seems to be. But I also, next one, because it's the same video. Okay, so he's watching on his monitor here. He can watch his own operation. Next one. Next one. Next. So this is 1 minute in recovery. I don't know whether your patients are awake. Next one. Yeah, another patient. Next one. See, we are lifting the legs all the time. Next one. So the CNC technique, a number of epidural attempts, first attempt, second attempt, or more than 2 attempts. You see 16 on the first attempt, successful, 4 on the second attempt. The depth from the skin to the epidural space, 5 centimeters. The depth of the tip of the TUI needle to the dura mater was 8 millimeters. Paresthesia by the spinal needle, no or yes. 19 had no paresthesia, 1 had paresthesia. Paresthesia during the subarachnoid injections, 0. Insertion of epidural was easy, 1 with blood. The duration of surgery, 1 hour. Duration of the start of the spine until the end of the operation was 78 minutes. The duration of the subarachnoid anesthesia from full onset of the block till full recovery was almost 3 hours. That's unbelievable. 1.5 milliliter spinal anesthesia, and it gives you 3 hours of anesthetics. Okay? The amount of fluids given, 2 liters. Conversion of the operation from laparoscopy to a laparotomy, 0. And from spinal anesthesia to general anesthesia, 0. So no conversions were needed whatsoever. Patients were sent home the same day. In 17 cases, 3 cases for surgical reasons, not for anesthesia reasons. All patients were fit enough to go home, but for surgical reasons, they kept 3 patients in the hospital. Next one. Motor blockade measured according to Bromwich. Half of the patients had no motor blockade before and after surgery, 95% of patients. No motor blockade whatsoever. Able to move unaided from the operating table to their bed in 95% of cases. Only 1 patient needed a little bit of help. Side effects, perioperative pain, yes, no. You see only 1 patient had a little bit of sufentanil or fentanyl, I'm not sure anymore. Itching, 2 patients had some itching. Shoulder pain, perioperative, well, 75% had no pain. And you know laparoscopic interventions create a lot of pain. Sorry, this side. Yeah. Post-operative, the majority, 90%, had no shoulder pain at all. Nausea and vomiting, nobody. Respiratory rate below 10, nobody. The use of sedatives, only 2 patients had some sedation. Pain relief, 14 out of the 20 had no extra pain relief. 4 patients had 50 micrograms, which is not a lot, and 2 patients had 100 micrograms of fentanyl. Ephedrine was just used on 2 occasions. Patient satisfaction score, 10, 9, 8 or below 8. You see 60% gave it a 10, 30% gave it a 9 out of 10, and 10% gave it a 8 out of 10. And all those patients who were not 100% satisfied were a little bit nervous. I can imagine for the very first time to undergo an operation while you're awake. It's not that evident. Next one. So advantages of this thoracic spinal combined epidural technique: omission of general anesthesia, well-controlled intentional segmental thoracic block, and from these levels, very few side effects, minimal impact on the hemodynamics, motor function, and the patient can follow his own operation on the monitor, and they can go home the same day. Next one. Yeah, you see here, okay, segmental subarachnoid thoracic anesthesia might expand the boundaries of regional anesthesia. It's a newer technique with potential adverse effects. It should only be performed by experienced anesthesiologists. This is not for the novice. You need to have the experience of epidurals, spinals, catheters, combined spinal epidural before you actually are going to do this. Okay, using minimal dose, that's so important, and a potential indication for cardiorespiratory compromised patients. And I will tell you one example. One of the patients I operated upon was for partial gastrectomy. Partial gastrectomy of a tumor. I did it with the technique. The patient recovered well, nothing problematic. But after 9 months, she came for a reoccurrence of the tumor, and now they had to do a total gastrectomy. But I was not there, and they gave her a general anesthetics. And the patient could not be weaned from the ventilator. So you see, it has certainly potential. Next one. And this is 1 minute after arrival in recovery. I think you would be happy to have all your patients like this in recovery, isn't it? Next one. So we published that in the British Journal of Anesthesia. Next one. So the best of two worlds with the fast onset and a better quality of the block, less motor blockade, more satisfied patients, fast onset, and the possibility of fast ambulation. Next one. So segmental spinal, is it possible? Naresh Paliwal was publishing on this topic, and I'm not revealing about the literature. The literature since then is overwhelming. The numbers of patients, I can't count them anymore, but at least 10,000 of patients have been revealed in the literature. It's very popular in certain places, like in Lampung, here in Indonesia, especially in India. It's very popular in India, in Italy, and you name it, a number of these. Next one. He wrote a book on the topic here, and he said Thomas Joneski proposed the term general spinal anesthesia in those days, and it was in 2006. He spelled my name, but anyway, that I gave spinal anesthesia puncturing at the T10 level. You see me here. I can't recall when we first met, but it must be 20 years ago or so. Next one. And so he wrote that book here, Paliwal, and I wrote the foreword. Next one. And since then, quite a number of publications. This is just a very limited list of the initial publications, how you can use it on different locations. Next one. The conclusion, segmental thoracic spinal anesthesia. It has lots of advantages. I'm not going to repeat them. Next one. And in India, they have a vapor journal. And they invited me to do an interview. Next one. You see here the high thoracic spinals, T5, T6, T4 till T10, T5 till T11, and this is in the lumbar region. So you can puncture at different levels. And these are the kind of operations that you can do and use these kind of volumes. Next one. So it is a new technique, but please be careful. It's not for the novice. I think you need to be very experienced before you actually are going to use these kind of things. Any questions? Or do we do it after last? After last. Okay, the last lecture. Sorry if I keep you busy. Yeah, but I hope this kind of lectures will initiate to introduce you new techniques as well. And this is very practical. But, yeah, pay attention. It should be very, very meticulous technique, very, very precise technique. Now, the last thing is about centrovenous access, an update on modern techniques to avoid complications. Next one. You see, I'm using all the time Udayana University. Yeah? Okay, next one. Okay, central venous lines, you know indications, you know the contraindications. I'm not going too deep into that. Next one. We can do that, yeah, for instance, in the jugular vein, in the subclavian vein. We can do that via the femoral vein, or we can do it in a PICC line. A PICC line, as you can see in here, via peripheral insertion. Next one. This is, for instance, in the lumbar region. You see the ligamentum inguinale. You see here the adductor longus muscle, and this is the sartorius muscle. Okay, it's in that triangle. And you need to know and remember it's always nerve, artery, vein. Nerve, on this side, it's vein, artery, nerve. That's very crucial. Otherwise, you're going to make errors and complications. Next one. Okay, so in this triangle, nerve, artery, vein. Next one. Yeah. And this is, for instance, the peripheral inserted central catheter, the PICC catheter. You see here the vein, basilica vein. This is the cephalica vein. Don't use a cephalica vein because it makes an acute angle here, 90 degrees. And it will stop here. Yeah. So use the basilica vein. Next one. So always fix it very carefully. Use the basilica vein, not the cephalica vein. And it goes all the way with the tip located here. Next one. So you see that here. Catheter comes in here. If you bring it from the other side, okay, but that should be the location. Next one. And fix it. And fix it good with sutures. And fix it. You see all kinds of side ports that you can use. So you can use multiple medication on it. Next one. There's suture wings here, but also there. And you have these clamps. Next one. Okay, next one. See here the catheter inserted. And this, the tip should be located somewhere here. Next one. Use ultrasound nowadays. I had to learn it, the blind insertion technique, with the landmark technique. But I was fortunate to have Philips, and Philips in Eindhoven, that's a very high-tech quality company, and they were focusing and they were bringing one of the first ultrasound machines. So that is how I got involved in the very early stage of using ultrasound. You see a few of my, there should be two more. I produced 4 of these things here, and how to use ultrasound for all kinds of plexus, upper extremity, lower extremities, you name it. Okay. Next one, but also for the ultrasound. So this is the artery, carotid artery. This is the vein, jugular vein. Okay. This is easy to do. This is more difficult to do. You understand that? And you see this kind of situation in patients, very obese patients. There's a lot of pressure on the outside. Next one. So we wrote an article. This is one of my PhD students, and this is me here, on the comparisons of the diameter, cross-sectional area, and the position of the internal vein and the carotid artery. Next one. And here you see, this is the left side, this is the right side. You see the position of the jugular vein and the carotid artery. Lateral, anterolateral, and anterior. And anterior on the left side, 15%, on the right side, 5%. These are the dangerous situations. You do understand, if you come with your needle in here and you pierce a little bit too deep, then you're on the carotid artery. Okay? If it's positioned like this or like that, then you hardly will end up in an artery. Next one. This is the left jugular vein, the diameter. Sorry, the right jugular vein, diameter, the left jugular vein. And this is a 14 French catheter, 12 French catheter, and 7 French catheter. Depending on what you're using here, you can have an idea how big it is that needs to be inserted in one of these jugular veins. Next one. So this is the carotid artery. This is the internal jugular vein, even with a valve. And this is with the guide wire. Next one. So this is, I'm not sure what kind of equipment that you're using. It usually has a syringe, has a needle, you have the guide wire, you have a dilatator, and then you have the multiple lumen catheter. Next one. This is another one. Next. Okay. What we want to do is we want to insert it in here with the tip in there. Okay, that is the location. Next one. Okay. So you see here the carina, and it's just next to that carina. Next one. You can use manometry, so the jugular vein pressure waveform to have as an extra way to make sure that you're in the right position. So aspiration is one, yeah, using of ultrasound is one, manometry is one, and you can use chest X-ray. Next one. Now I think it's a month ago that we produced this article in Healthcare, a review article on central venous access, an update on modern techniques to avoid complications. I think it's important. Next one. You know that the first catheterization was done on a horse, yeah, in 1733. They were measuring the pressure into the vein in those days. I only have seen this thing. I've never read anything about it. Next one. So this is, for instance, confirmation. Yeah, this is the short axis, long axis. This is manometry. This is chest X-ray, echocardiography, chest X-ray. This is the toe. Next one, all kinds of techniques to make sure that you can verify where exactly is the location. Next one. So the jugular vein with the external one, internal one. Next one. That is where you want to insert your needle. Next one. Okay, next. And obviously there are complications. Like with any technique that we do, there are always complications. Can be a pneumothorax, hemothorax, malpositioning, arrhythmias, air embolism, and arterial perforation. Next one. Now, immediate and delayed complication. Immediate and delayed complication. Total number of catheters and the complication rate. You see failure in this particular study, 2% placement failure, 1.6% arterial puncture, 0.28 arterial cannulation, and 0.44 pneumothorax. This is a very recent study. So still complications do occur, and delayed one, deep venous thrombosis and infections. Next one. Historical, you see this is in the 1970s, 1980s, 1990s, 2000, and just recently. You see the number of complications decreases, like placement failure was 6.5% long time ago. Arterial puncture 19%, now much lower. Pneumothorax 6%, now 0.5%. Okay. Deep venous thrombosis and infection still occurs. So despite all our modern equipment, modern, all our aspiration technique, all the things that we can use, we still have the problem. Next one. Yeah. Ultrasonography certainly is better than the landmark blind technique. Okay. So on all occasions, all these complications are less with the ultrasonography than with the landmark. But they are not zero. It is still occurring. These are recent publications. Next one. You see that for the jugular vein, the femoral vein, and the subclavian vein. You see the least complication rate is with the jugular vein. The femoral vein is 2.8%, but the subclavian vein is the one with the most complications, 3.6%. Yeah, next one. Now what to do, there's an algorithm, we produced that in healthcare just recently. If you have an inadvertent arterial puncture, inadvertent pneumothorax, or an inadvertent retained guide, what to do. I think it is good. This is, you easily can get access of this journal for free, so it should not be a problem. So if you have an arterial puncture, then it's always good to see whether it is an accidental puncture of the artery, and can the artery be easily compressed. If yes, then you can pull it out, and then that's it. But that is for the internal jugular vein. You can't do that, for instance, for the subclavian. That's too difficult. If you have dilated and accidentally punctured and put in the catheter, then don't do anything. Leave it in, don't pull it out, because if you're going to pull it out, it will create a lot of bleeding. Just leave it in, ask a cardiovascular surgeon or vascular surgeon or an interventional radiologist to take it out under vision in radiology and block the opening. That is what you need to do. With an inadvertent pneumothorax, it can happen. Respiratory impact can happen. You can have a pneumothorax, you can have a pneumothorax. Sometimes there's a need that you need to do an insertion of a catheter to withdraw the air out of it. And inadvertent release the guide wire. Sometimes you need a vascular surgeon to take it out. Next one. And sometimes it can be difficult. In these kind of patients, you see a very obese patient. Access to certain regions can be very difficult. No neck, but also no space in the inguinal area. And there's not a single vein to be seen on the arm or the hand. Next one. See that here. Have all kinds of problems. Next one. See that it's very difficult. So do not do this kind of anesthetics alone. You always need a second hand. Next one. And you see how difficult it can be. Although I managed to do a few of these cases, and to help them. Next one. So this has been published. Next one. This is too extensive. Okay, next one. Next. Okay, use ultrasound all the time. Whether it's supraclavicular or in the subclavian region. Next one. Now, PICC lines. You would think, okay, peripheral inserted central catheters, that's the solution. Let's use all the time PICC catheters. In fact, it's not a good solution, because the complication rate is much more. We just published that in another journal. Next one. So use the one here, this one, brachial, and the basilica vein. This is the cephalica vein. Don't use this one, but use this one. Okay, so the basilical vein, this is the brachial vein, and this is the cephalic vein. Next one. Okay, so use only the basilica. Next one. PICC line coatings. We have now antimicrobial coatings, antithrombogenic coatings, and valve PICC lines. So they come in a huge number. Next one. But the complication rate, as you can see here, the complication rates for all aspects is much higher than for central venous catheters. So my advice is use central venous catheters and not PICC lines. Because suppose you have to give anesthesia to that very obese patient. You have a PICC line inserted. The complication rate is very high. Sometimes 30% of all these catheters have complications, obstructions, kinking, you name it. And all of a sudden you're exposed to a patient where you have no access, no venous access. What are you going to do? Inserting another line? No, it's not possible. Yeah, and inserting another, especially if there's a head operation, you can't have access to the neck, for instance. Make sure that you have a good venous access all the time, but don't rely on big catheters. Big catheters have the second highest complication rate in a hospital after hemodialysis catheters. So we don't have them even in the operating theaters. We don't have them in the intensive care. We are not using that much of peripheral catheters. They only are used on the wards, on patients who do not need to undergo any surgical intervention. Next one. Next one. Next one. Okay. Potential locations of intracava and extracava catheters. It can end up anywhere. Next one. Complications of peripheral catheters access. Next one. So lots of venous thrombosis, phlebitis, thrombophlebitis, catheter failure, occlusion, fractures, related infections, etc. So there are far too many complications to advocate this technique. Next one. So the common perception that peripherally inserted central venous catheters cause fewer complications than central venous catheters is a misconception. While it has some advantages like ease of insertion and lower risk of infection, they still can lead to a variety of complications, including thrombotic events, which become more frequent than with central venous catheters. Next one. So use these catheters, but not the big lines. Next one. Thank you very much for your attention.
Discussion. Question regarding third or fourth topics. Raising
I think they become bored with my lectures now.
Maybe I'm gonna conclude maybe for the third topics, the comprehensive exploration about the thoracic spinal anesthesia. The discussion today highlight how this technique offer targeted anesthesia, faster recovery, and reduce systemic side effect, which making become a valuable alternative, especially for patients with higher risk with general anesthesia. With every examples that already been aforementioned. As evidence grows for its safety and effectiveness, thoracic spinal anesthesia stands out as an important option in modern perioperative care, provide patient selection and technique are carefully considered, and also it's especially we need to give a concern if you're very experienced in this technique, we really can relay on this kind of techniques. And then for the fourth topics regarding the central venous access, how to deal with complications. This session emphasized that while central venous catheters are invaluable in patient care, their use is not without risk. So we should emphasize every techniques, every like me myself, just the PICC itself having so much risk, around 30% maybe, all the risk will be higher in PICC. So not be too much afraid while using the central catheters, but every like using the ultrasonographic will increase the successful rate and reduce the risk. Maybe from the audience, do you have any questions for the third and fourth topics?
either a central one, probably in very obese patient, that's the way to go, yeah, or a peripheral one. But at least you need two catheters. Don't rely alone on that big catheter. That should be the message. Now, do we need the big catheter or we need the central venous catheter? I told you, in my hospital, in the operating theaters, we have no big catheters. In intensive care, we do not insert big catheters. We don't even have them. Okay? It's only for the ward or whatever. Not in intensive care, in emergency medicine, or in anesthesia. So that tells me a lot, isn't it? That tells me that another technique must be better, because otherwise an anesthetist would have used this. So my first conclusion is central venous catheters are the better option, but it will not be the easiest option. The easiest option would be to put in peripheral line. And sometimes you can do that with ultrasound, especially in patients with a lot of edema. Push the edema away. It takes you a minute or so to push the edema away. Even if it is 2 centimeters, you can push it away, then all of a sudden you can see a vein. Use your ultrasound machine to put in the catheter. That is how I solve the problem. If that is not possible, there's nowhere that I can see a peripheral vein, then I put in a central. Is that somewhere the answer that you were expecting?
Yes. These are my questions. Thank you.
Thank you.
Questions, maybe, from the audience?
Hello, Professor. My name is Caitlin, and thank you for the opportunity. I'm one of the medical students, and I want to ask for your third lecture for the new technique. It was such an amazing insights, even though I'm not able to perform it right now. But I was wondering, why do we have to do the spinal first and then the epidural? Besides, for the reason that the spinal anesthesia has a faster effect. Do we have like another reason, or is there?
Well, of course you could think, why don't we put in epidural catheters? Yeah, but then you have to use so much local anesthetics that you don't know anymore where is it going. You understand? So the hemodynamic repercussions will be much more. Now I'm absolutely sure, I know the subarachnoid, this is the block I'm going to realize, and that's it. With the epidural, you are not sure. It can go up very high and also very low. That's not what I want. I want to have a restricted block so that my sympathetic and the sympathectomy is not total.
Oh, so there is the reason is so you can only like block the for the area of your interest, right?
Yes.
Okay.
Yeah.
I think that's all. Thank you very much.
Thank you very much. So depending on where you're going to insert your needle, is it in the high thoracic needle? You've seen Dr. Ionesco did even skull operations. I don't know exactly which kind of skull operation, but he did also operations on the cheek and on the face, etc., with spinal anesthesia. I don't know anybody in the world at this particular moment who's doing this kind of operations under spinal anesthesia injected into the cervical. Maybe we need to review all these kinds of patients in detail if they are written down. But at least UNESCO produced 400 of these patients, and that was in a time span of 8 months or so. It was very busy.
Just to make sure, so we use an epidural for the post-operative.
Yes, but that's different. Yeah, epidurals obviously can use, but look, we need to be careful. With the bupivacaine, you do not want to have the large extent. But with the epidurals, you also can use, instead of local anesthetic, or a combination of local anesthetics alone, with sufentanil or with fentanyl. That's the beauty. Yeah, that gives long-lasting pain relief with a limited amount of local anesthetics. But the local anesthetics are still essential.
Prof, is it mandatory that we use hyperbaric bupivacaine?
No, don't think that you always need to use hyperbaric. Of course, it depends how you do the injection. If you do the injection with the patient in the sitting position, then depending on what kind of operation, if you want to go that the block goes all the way down, then you use an hyperbaric solution. If you want to go the block a little bit up, then you use an isobaric or an hypobaric. That all depends. If you put the patient on the side, again, if you want to have the operation on the side, sorry, you use an hyperbaric solution, but sometimes it is better that the patient lies on the side and not, for instance, with the fractures here. If the fractures are here, you put it in the patient on the side, and then you use an hypobaric so that the block goes up. But you need to work with the circumstances and the patient and the actual situation. So be flexible.
Thank you, Professor. I'm gonna for the question from the online. Thank you for the interesting lecture. Can spinal segmental at the level T4 or above possibly be done safely without disturbing the cardiac excellence?
Yes, that's one very good question. What are we doing if we are going up very high? Now, I've inserted many cervical epidurals, and I never saw really an impact on the cardiovascular issue. Well, there are many other reasons in the physiology of the patient that keeps the heart in a stable position. So I'm not too worried about it. Obviously, never block the whole thing.
Is there any time we need to wait if we're using hyperbaric solution or hypobaric solution? Is there any recommendation how much time we should wait for the patient to stay in this position?
No, look, usually we need some time to insert the block, then the positioning of the patient, then the cleaning and all the, so the preparation usually is 10 minutes. And that's enough for spinal anesthesia. That's always good.
Suffice our discussion for today. Is there any more questions maybe from the audience here?
I would like to ask a question. Yeah. Okay. Now, thank you for all your attention all the time, and I'm sure that this is a long time having lectures for 4 years, for 4 hours. How do you evaluate? Please give me a little bit of feedback how you evaluate it, whether you see this is a good option, bad option, or whether we should change the formula. Please feed me, because it's also good for me, and I always want to learn from my errors.
From the audience, is there any feedback?
If you don't want to say it now, it's also perfect. You can say it to our leader, and perhaps he can communicate it with me at a later stage. Okay? That's all.
It's very good.
Because the negative things, perhaps you say it to him and not directly to me. Okay.
It's very good option, Professor. Maybe I'm sharing our experience here. Maybe for the last topic in the vein or central catheters. In here we usually using it's regular basis using ultrasonography to reduce the risk and complications. Or using we are using several steps to ensure that the catheters will be inserted in the right place. First one using the landmark, then we really use landmark, and then we suffice with using the ultrasonography to ensure it's the right vein. And then after we using we puncture, and then using the guide wire, we ensure the guide wire is right in the internal jugular vein using the ultrasonography by using the short axis and also the long axis. And sometimes we using sertraline to ensure the tip of the catheters is the right place. Then lastly, we're using the mobile X-ray machine to ensure the tip of the catheter just right inside the cardiac. Yeah,
Perfect.
maybe it's very
I think that's the wise thing to do. Each and every step that you take, make sure that you have a little bit of a confirmation, that you have that you bring in little steps by step, so that the final position of your catheter is in the correct position. But still, it will happen. Look, I'm old enough to have had my own incidents, complications, you name it. Yeah. And if you are long enough in anesthesia, you're sure you will have your share of complications. Okay? But learn from the complications from your colleagues, not from yourself.
Experience is much more better than our
Of course, then you can talk with him.
Yeah. Okay, maybe that's all.
And I have to do some ultrasound.
Yeah.
Oh, after that. Okay. Good.
Thank you very much for our speaker for the insightful and engaging presentation. We truly appreciate the valuable knowledge we shared today. Now we'll have to take a break for lunch. Please enjoy your meal, and we look forward to seeing you back here in the next session for the workshop using the ultrasonography for regional.
Okay. Thank you. Good. You're a good chairman.
Udah boleh. Nggih, silakan dari Bigdon, Bu Cici, Bu Retna yang mewakili.
Ya, selamat siang dokter.
Oke, selamat siang. Silakan dulu.
Ya, saya boleh izin share nggak dok?
Dari Bu Cici yang mau share screen
Iya,
atau dibantu
ya.
oleh panitia?
Boleh saya share dokter?
Oh iya ya, oke.
Ya. Baik, terima kasih. Selamat siang dokter semua. Terima kasih udah ngasih kesempatan ke Bibron hari ini mau presentasi. Mungkin produknya udah ada di sana, cuman reminding aja sih ya ini Dok, saya izin share ya. Oh, sepertinya saya nggak bisa share ya Dok ya? Oh, bisa.
Ya sudah bisa. Suaranya nggak kedengeran, Bu Cici.
Oke, saya coba ya lagi. Halo, udah kedengaran belum Dok?
Oke, sudah. Silakan lanjut, Bu.
Oke, maaf. Nah, hari ini saya akan mempresentasikan salah satu produk dari Bibron, Sterofundin. Mungkin di sana di Sanglah udah kenal ya dokter-dokter semua. Ini hanya reminding. Kenapa kita presentasikan Sterofundin? Karena kita mau mengenalkan konsep sebenarnya balance solution dari Sterofundin ini yang kalau di Eropa di sana dikenal dengan full plasma adapted, benar-benar sama dengan plasma darah. Elektrolit yang dikandung dalam Sterofundin sama, persis sama dalam plasma darah, isotonis 280 sampai 300. Anion kationnya itu metabolismenya seimbang. Kemudian acid base-nya juga seimbang. Asam basanya di dalam Sterofundin ini sangat seimbang. Jadi teknologi dari Bibron itu menyeimbangkan, ini benar-benar balance solution full plasma adapted. Ini adalah kandungan dalam Sterofundin, natrium, ada 145, kalium, kalsium, magnesium, kloride, asetat malat. Di sini biasanya mungkin dokter mengenal ringer laktat dengan buffer laktat. Ada ringer asetat. Nah, di dalam Sterofundin agak unik, tidak hanya mengandung satu buffer, tapi mengandung dua buffer, asetat dan malat. Biasanya kalau banyak penelitian di luar itu bilangnya Sterofundin ini RAM, ringer asetat malat. Osmolaritasnya 250, osmolaritasnya 309. Benar-benar isotonis. Kenapa dibilang Sterofundin full plasma adapted? Bisa dilihat di sini, di kolom sebelah kanan itu plasma darah, yang tengah adalah Sterofundin, dan ini komposisinya. Mengandung natrium hampir sama, 145 dan 142. Kalium, kalsium, magnesium, kloride, kemudian asetat dan malat. Kenapa kita menambahkan malat? Nah, ketika dokter mungkin nanti bisa dilihat di tabel seterusnya, ketika ada beberapa produk di market, ringer laktat maupun ringer asetat, kalau dijumlahin itu nggak akan sama elektrolitnya. Nah, di sini kita benar-benar sama seperti plasma darah, isotonis, kita laktat free, kita mengandung asetat dan malat. Kenapa kita malat? Karena kita mau menyeimbangkan kloride. Jadi biar mendapatkan elektrolit yang seimbang dengan isotonis, kita menambahkan malat untuk membuffer dari kloride kita. Satu malat bisa menghasilkan 2 bikarbonat. Satu asetat hanya 1 bikarbonat. Kita laktat free karena kandungan laktat itu sangat berat, metabolismenya di hati, untuk asetat dan malat itu di metabolisme di otot. Ini acid base Sterofundin 5 mmol, ini bisa dilihat ini dari beberapa penelitian, asam dan basanya sangat seimbang. sehingga tidak mengganggu metabolik asam basa di dalam tubuh. Nah, ini adalah comparison kristaloid di Indonesia. Mungkin dokter bisa ngelihat ada beberapa sediaan, mungkin ada ringer laktat, ringer asetat, dan RAM, ringer asetat malat. Bisa dibalik, sediaannya di belakangnya itu ada komposisi, bisa dijumlahkan. Ringer laktat kalau dijumlahkan osmolaritasnya hanya 277. Ringer asetat juga 273. Karena apa? Karena natriumnya itu mereka kurang dari plasma darah. Plasma darah 142. Ringer laktat dan ringer asetat hanya di 131 dan 130. Karena apa? Karena mereka ingin menyeimbangkan, menurunkan klorid. 112, 108 karena klorid di dalam plasma darah ada 103. Untuk sterofundin memang agak tinggi kloridnya, tapi kita buffer dengan malat. Yang tadi satu malat bisa menghasilkan 2 bikarbonat. Jadi kenapa tidak terlalu tinggi kalau misalnya kita jumlahin itu kurang lebih 112 juga. Karena kita di sini menambahkan tadi malat yang bisa menyampai 2 bikarbonat di dalam darah. Untuk tonisitasnya bisa dilihat di sini, sterofundin isotonis di 309. SID-nya juga mendekati plasma darah tubuh manusia, yaitu 29, yang lain 31 dan 32. Ini SID di in vivo. Jadi inilah kenapa di dalam sterofundin itu mengandung asetat dan malat, dan bedanya di sini sterofundin mengandung magnesium. Kenapa sterofundin atau RAM disebut sebagai full plasma adapted? Karena mengandung semua elektrolit yang ada di dalam plasma darah. Ringer laktat maupun ringer asetat tidak mengandung magnesium. Ini adalah comparison atau perbandingan sterofundin dengan sediaan yang lainnya, ringer laktat maupun ringer asetat. Kenapa kita tetap memberikan di dalam sediaan kita magnesium? Karena ada beberapa penelitian magnesium sangat bagus untuk operasi jantung. Nanti ada penelitiannya. Ini adalah guideline November 2024 di Eropa sana untuk pasien-pasien yang critical ill. Di sini mayoritas menggunakan evidence-nya menggunakan balance solution dibanding normal salin. Jadi di sana sudah melarang pasien-pasien yang ICU critical ill menggunakan normal salin. Mayoritas menggunakan balance solution. Ini adalah penelitian sterofundin sangat aman pada pediatrik, pada anak. Beberapa ini ada penelitiannya bahwa dapat menyeimbangkan hemodinamik pada anak, kemudian sangat aman diberikan pada pasien anak. Nah, ini salah satu penelitian juga sterofundin sangat bagus untuk pasien dengue severe. Ini penelitiannya pada anak usia 1 bulan sampai 18 tahun yang mengalami diagnosis demam berdarah severe yang udah parah. Conclusion-nya asetat malat, RAM, asetat malat atau sterofundin lebih efektif sebagai fluid choice pada resusitasi pasien yang mengalami demam berdarah severe atau berat dibandingkan dengan ringer laktat maupun normal salin. Ini adalah penelitian pada operasi jantung yang dilakukan di luar maupun di Indonesia di rumah sakit Harkit. Jadi di sini ternyata pasien yang diberikan sterofundin dengan mengandung magnesium dapat mengurangi terjadinya atrial fibrilasi. Jadi magnesium di sini sangat berpengaruh pada pengurangan terjadinya atrial fibrilasi pada pasien pasca bedah jantung. Dan sebelahnya adalah penelitian pada brain injury. Ternyata di Indonesia juga sudah banyak penggunaan sterofundin pada pasien-pasien yang mengalami pendarahan dan brain injury atau operasi bedah saraf, karena ternyata di dalam sterofundin tadi mengandung natriumnya sangat tinggi dibandingkan ringer laktat atau ringer asetat. Di mana ini setelah saya diskusi sama beberapa bedah saraf, ternyata sangat bagus untuk potensial aksi atau pengiriman pesan sistem saraf pusat after neurosurgery. Ini ada penelitian kita lagi coba PNPK dan masuk ke Fornas, lagi proses di Kemenkes dan Perdatin. Ini keunggulannya faster daripada hiperbarik, cepat regresi, cepat onset, juga terjadinya urinary retention-nya sangat rendah, bahkan tidak ada. Hemodinamik pada pasien diberikan dengan tachypnea itu sangat aman. Sekian presentasi dari saya, terima kasih. Mungkin ada pertanyaan, dokter?
Terima kasih banyak nih Bu Cici ya atas presentasinya ya.
Ya, sama-sama dokter.
Ya, izin kita lanjut nggih, Bu nggih.
Iya, baik dokter.
Iya, makasih banyak.
Terima kasih. Saya izin lip ya dok.
Ngiring, ngiring.
Adik-adik semuanya siang. Firstly, on behalf of the department and the study program, this once and twice thanks for the so everybody must know that is our distinct profession. Firstly, we need it was 1 year ago we become very disciplined, and nowadays Prof. André, we have proposed Prof. André to have award of the Dr. Honoris Causa from our university. So Prof. Not just for the academic, this also give us as the reviewer of our regional anesthesia or regional pain management. Okay. Professor Van Zundert start workshop and answer.
Okay, ladies and gentlemen, it's always a pleasure giving a little bit of a workshop about more practical things. And it's also a challenge because I'm not very used to this system, so I can have troubles. And the first thing is to know your equipment. The first thing to know is to make sure that you really know. Example right now, because I don't know it. But anyway, I will try to do my best. Yeah. Then the patient, they need to be positioned in the most optimal position. Now, what is the most optimal position? You have that special pillow for me? I need an extra pillow. First of all, the position of the patient is very important. Okay? If you want to do a plexus block here, then you need to have access. Now, is it good to have access like this? This is not good. I'll show you. What we need to do is just lift your head and make room. So put him at the, see the difference? Now I have total access. So now I have more access. See that? So that's one thing. Second thing is make sure that he has a pillow so that the patient is comfortable. Patient needs to be comfortable because sometimes it takes half an hour to do everything. Okay? So make sure that you know all the ins and outs of the equipment. That is very important. Second, the position. The position of the patient is very important. Okay? You need to have full access. You need to have full access to the patient. Okay? And the positioning of the arms should be like this. Not like this, not like that. Let's put it on. This is a very wrong position. Don't use it. Because sometimes the arteries will be obliterated, will be collapsed if you do it. It's not a good position. Okay? Make sure, side here. And I know anesthetists, there are anesthetists who are doing the block from here. I want to do the block from here. It's just to give him that extra exposure so that, that he lies comfortable. Okay? That is what I want. I'm going to take it away now. And sometimes we put it under the legs. Yep. Okay. It makes people more comfortable because many elderly patients have back pain. And if they have back pain, this will help. Don't forget, positioning is very important. Okay? Make sure that they are comfortable and ask the patient whether they are comfortable. And talk to the patient. If I'm standing here, the patient will have an odd vision of myself. So it's better to stand here, do the blocks from here, but stand on the side where you're going to do the block. Now, in order to be able that you can see it, I will stand on this side so that you can see as much as possible. Yeah? It's also going to be over there. And I think it's recorded so that you can see it afterwards. Perfect. Okay. Make sure that we have full exposure. Now, I'll take this out. So that I have exposure here to, I told you, make sure that you have a lot of exposure here. Okay, just lift it. So I'll do it on that side, a little bit more. Just at the edge, so that I have now more exposure, a little bit more. Yeah. Now I have full exposure. Now I can have the whole area. So if my needle comes up like this, from that side, I have a lot of space. Understand? That's so important. Okay, let's do first thing first. Turn the head on that side. If we want to show, okay, what we want to know is there's always a little indicator. That's the indicator on the left side. You see that? the left side. Yeah? That point, near the F. And that's good. And hold it in your hand like this or like that. Okay? Right hand, left hand, doesn't matter, but that should be that side. Okay? Then, for instance, if you want to do a supraclavicular, just a central venous catheter line, what you do, make sure that you use your landmark system first and then just insert. You're going to see it immediately what you want to find. Okay, a perfect example of a jugular vein and an artery. See that? And if I push hard, the vein collapses. I was not pushing that hard, but anyway. Okay. See that? What is this nerve? Oh, how to do that? With a pointer. What? Oops. Sorry. Okay, can you use it over there? One second. Okay, so in between we have a nerve here. In between we have what is that nerve? Any idea? It's a vagus. Don't block the vagus. Just to give you how to do it. Okay, so so if I want to insert a central venous catheter, you easily can understand it's easy if I want to do that here. I bring my needle in, out of line, not in line, but out of line. I come difficult. You have to turn all the time, but anyway, so you come out of line, come out of line, and make the insertion in here. You try to avoid the artery. Yeah? That is the first thing. Now it's interesting. If I want to do a plexus block, I make sure that that upper left point, yeah, is going to be in here. And oops, and I still see the artery, the vein. See that? But what else do I see? So it's difficult. Don't you think it's difficult to distinguish arteries, veins, plexus? So it's better to do it in a reverse way. Feel the clavicle. You feel the clavicle here. You go in here. You look into the thorax. Okay. Look for the artery. See the artery? This one here. Okay. See the artery just above the clavicle. Here I see the plexus next to it. Lateral to the artery, I see the plexus. Yeah, but yeah, I know, but if I do it there. So this is the artery, and the plexus is always on the lateral side. So make sure that you have this point now on the medial side. This is medial, this is lateral, this is the clavicle, first rib. You see here the artery, the subclavian artery. On the lateral side, you have the plexus. See the plexus here? So it's much easier to find the plexus first if you look into the thorax. So I'm looking into the thorax. And then I go towards the ear, towards the earlobe. Okay? So I make a movement towards the earlobe and have a look what we see. See the plexus here? I'm going now up and up and up. You see these plexus here? Here is like a grape of, like grapes. But if I go up, then it's like a string of nerves. Okay? Any idea what is this one? Most probably this is C5, C6, C7, and C8. Okay, so you have a whole string. You actually can see exactly where you are. This is now much easier than going directly to the interscalene. Understand? It's much easier. Now, depending how you need to do an operation. You need to do an operation on the shoulder, upper arm, elbow, underarm, the hand. How to know that? The idea. You have to do a shoulder operation. Then you need to know the anatomy. The anatomy for the shoulder is C4. I'm going to show you. This is C4, C5, C6, C7, C8, C8, T1, and T2. You need to remember that. That is very important. I repeat it once more. Okay, C4, C5, C6, C7, T8, T1, and T2. If you want to understand, you need to know this sensory interface. It's also good to understand what is the motor interface. Any idea how I can find out what is the motor interface? I'll do it for you. Okay, I have my arm here. Raise my arm. That is C5. Okay, if I bring it back like this is C6. Okay, if I do this one, that is C7. If I do this, C8. If I do this, then it's T1. So you have to learn that. I'm very sorry. Yeah, okay, I'll repeat it once more. So, arm like this, you lift it, C5, C6, C7, C8, T1. Okay, so at least you know now the sensory innervation and you know the motor block. Okay, because you are going to evaluate your motor block. After this block, this plexus block, you need to find out, is it sufficient to allow the surgeon to do an operation here or here or here? You understand? And you want to know, okay, can you lift up your arm? If he can't, it's always a good sign, of course. Yeah. But if he still can lift his arm, but certain things he can't do anymore, then you know at least, okay, I have blocked these and these nerves. So that's important. Understand? All good. Patient knows it. Good. Okay. So that's that. Now, if I want to do an interscalene plexus block, that's very good, and it's good to make sure that we have these operations here. Now, you can do all the way from this angle here, all the way till the mid-clavicular region, you can do blocks. Doesn't matter where exactly you are, you always can find the plexus block. It's very important. But the lower you go, you must be sure that you have covered everything. Okay? Now, if you have an operation here, then you go lower. If you have an operation here, you go higher. Understand? The higher the block, the higher the region where your surgeon is going to operate, the higher you have to come up to plexus. Okay? Okay, let's show it once more. Make sure left upper lesion, that one here, it's with that indicator here. Okay? Look it up into the thorax, and you immediately see your artery. Okay? The subclavian artery with the plexus just over there. Okay? Then I go up. You see that there's different nerves. Okay? This is all the way up. If I go higher, then you can see it here. Okay? And C4 is in the anterior muscle. So we have an anterior muscle and we have a middle scalene muscle. Anterior scalene, middle scalene muscle. There's also a posterior scalene muscle, but that's not of interest to us. So it's the anterior one, close to the artery, the carotid artery, and the vein. Okay, so the jugular vein, carotid artery, anterior scalene muscle, all the plexus block, the plexus nerves here, and we have the middle scalene. It's important to be in here and do the block here. If you want to do an upper surgery, go down. If you have to do a lower surgery, okay? So upper surgery, for instance, here on the shoulder. Lower surgery, if you have to do, for instance, hand surgery. Okay? Now, you can do, for instance, a block. Just make a little bit. So this is in the incisura jugularis, in the middle here. And I feel here the acromioclavicular joint. Okay? You take a straight line and go in the middle. And why is that important? The importance is because you can do a subclavian. Now, this is the thorax. So if I feel this is my thorax. So if I go all the way up, okay, I go to that middle here. See that middle? If I stay out of this place here, I can do a perpendicular block. Do a perpendicular block here. It will not create a pneumothorax. Understand? So you have to put the indicators first here, incisura jugularis, and this is acromioclavicular joint. So take a straight line, in the middle, exactly in the middle, that is where you want to go perpendicular to the skin, just below the clavicle. Understand? And I'm outside the thorax. That is so important. Outside the thorax, so I can do the block here, so just in the middle. And can you feel it yourself? Can you feel it with yourself? Go just above the clavicle, just in the middle. Can you feel your plexus over there? Just rub it a little bit to the side. You can feel it. You can push it against your first rib. You feel it? How's it difficult? Can you do it yourself? Can you do it yourself? So one finger. Okay, just in the middle. Push against the first rib. And you will feel the plexus. In fact, if you want to do plexus block on children, let them sit, yeah, with their mother on their knees. Let them sit, and you can do very easily. It comes very close to the skin, so it's very superficial. You actually, if you rub it, it's in fact a little bit painful. Not that pleasant. Can you feel it? You really need to do it. Use your ultrasound machine one day to find the middle here. It's very, very easy to. Okay, so that's another thing. So you can do blocks here. You can do the block in the supraclavicular area. That's what we have demonstrated next to the picture. So we have already shown you a few of these areas. So close to here, that's the scalenus block. Between the scalenus anterior and the scalenus medius. Okay, that is what is called the scalenus block. show you once more. I come from here. Okay, that's a subclavian artery, plexus block that we see here. This is what we call the Coulombkamp technique. So, yes, the Coulombkamp technique used a lot for supraclavicular block. You are just in the middle of the plexus, and virtually the whole arm will be anesthetized. It's a very good one, but there's one disadvantage. Go in the middle. Okay. If I take my finger here and I push it here, what do I feel? Just medial. Can you feel it? That's your lung. That's the top of your lung. There's one place at the top of your lung comes above the clavicle. That's here. So if I put in a needle, yeah, and I'm too medial, then I have a pneumothorax. Need to avoid that. Okay? So that's the disadvantages of if you do a plexus block just above this area. Because if you are too medial, you will puncture the lung and you will have a pneumothorax. That's the disadvantage. If you go up, then you have all these nice things here. That is the interscaline. Between the scalene anterior and the scalene medial. Interscaline block. Okay? If you need to operate on the proximity, then you go up. If you do it more lower, then you go in the lower section. Okay? But you specifically can, especially with these kind of machines, the ultrasound machine and a nerve stimulator, they will explain you exactly, okay, you're now here, or here, or here, or here. Okay? So that's important. Okay, so we have done supraclavicular block, we have done the interscaline block, we have done also the infraclavicular block. The infraclavicular block, I can show it to you, but it's not that easy. Yeah? See, here's the artery, and you have the nerves around it. It's not that easy. I would recommend that we are using the system, then just make two indications here. Take a full line, go halfway, just use a ruler, go halfway, and from here to there, halfway, and stay out of the thorax. So it's very important that you know the thorax is completely on medial side. Okay, so interscaline, supraclavicular, infraclavicular, but you don't hardly need it. But suppose there's an indication you have to do it. Yeah, and then you can go all the way. Take this one. Now, if you have the arm like this, just can you hold it for a moment? We can do the blocks here, interscaline, supraclavicular. Okay. Okay, so we can do an interscaline block, a supraclavicular block, an infraclavicular block, and all the way till here. So it's like a line. Okay, it's like a road. A road for the anesthetist. We can block it anywhere on this line. Okay, all the way here. Now I'm going into the axilla. Okay, you can move this again. Yeah. I bring the knee, the arm in like this. So like this. Not completely like that, just like this. And now we have the indicator on the top side. Okay, and I'll go into the axilla and see what we can see here. Okay, make it a little bit darker. You see the artery over there? It's more difficult to show it here than to show it on the on the monitor of the machine itself. Okay. Now we need to show, can you do the same with this arm? Okay. We need to show the biceps, and this is the triceps. Okay. And in between are the nerves. Okay, we have here the axillary artery, and the axillary artery is surrounded by nerves. Okay, and so this is the median nerve, and here is the ulnar nerve, and on this side is the radial nerve. See that? So it's a little bit around the artery. Okay. Once you are doing these blocks yourself, you easily can distinguish it much better, because this obviously is an image from that one. Now you have the ulnar nerve, the median nerve, and the radial nerve. The radial nerve is at the back side. The median nerve in the middle, and the ulnar nerve is on the most median side. But there's one nerve that we don't block. If we only block this one, you know which one? It's this one, the C5. The C5 you need to find here. It's in here. See that? This region. That is the C5. It sits, makes movements. You see, this is the biceps, this is the triceps. And in between, you have this nerve, the muscular cutaneous nerve. Muscular cutaneous nerve, you have to block separately. It's not too difficult to do that, but you have to do that whenever there's an operation on this side. The lateral side, it's important to do that lateral side. C5. So it's important that you know your anatomy. Okay? That's where it is. So it's a little bit deeper, depends on how muscular the patient is, with your biceps and the triceps at the bone. Biceps, triceps. Okay? That is what you need to do. Obviously, this is good for any surgery under the elbow. If you need to do it on the upper extremity, then it's better to go above the clavicle. If you need to do operations on your forearm or your fingers, you can do that with an axillary block. Good. Clean up a bit. Now what else for blocks can you have? Again, make sure that it's on top of it. Because now I'm going to look into the thorax. And if I'm looking the thorax, what do you see now? You see a rib here? Yeah, and you see a rib over there. And in between you have nerves. So I know that the ribs are following this trajectory. And where do you have to block it? Above or below the rib? Any idea? Where do you put in a drain? If you put in a drain, a thorax drain, then you have the anterior line and you have the median line. Okay? In between those two, you put in the fifth intercostal region your drain. Okay? To relieve a pneumothorax. And you go above the rib. And above. Because nerves and veins and arteries are below the rib. So for regional anesthesia, you go below the rib. drains, you go above the rib. Okay? Now, if this, for instance, is the rib, then you go below. So how do you do that? You walk over the rib till you drop a little bit. Understand? So you go from above, then below, all of a sudden. And it's not that deep. But if you do, for instance, if you have a very bad situation, you want to do an operation on the abdomen, even a cesarean section, you do the lowest 6 blocks on this side and on that side, you can do a full operation on the abdomen. Understand? It's how good these intercostal blocks work. But obviously, then you need to know how to do these blocks adequately. Yeah? So you can even do a cesarean section without anything else. That's that. Okay, what else can we do? Now, if you need to take off your trousers. Take off your trousers. And now you take off your trousers and you leave this on top of it. Yeah, is that okay? Go ahead, I need to be there. Okay, now, if you want, now we are going to do this. Okay? There are a number of blocks which are very useful to take away pain. Okay? One of them is that you need to understand the anatomy of this region. So, for instance, if I go here, what do I see? What is this? Maybe more clearer now. What is this here? Show it on that side as well. What is that? What is this? Any idea? The rectus muscle. The rectus muscle, see that here? This is just above the umbilicus. This is on the other side, the rectus. Okay? You see 2 sheets, 2 fascia. In between there's a nerve here. And if you block that one and that one, you can relieve pain in this region. So it's very useful if you have an operation in the lower abdomen to take away the pain, especially in the midline. Okay? That's one thing. Now, if I go to the side, so that's your rectus muscle. Okay? You see the nerves are sitting in between those 2 lines. Okay? So the only thing what you need to do is come with a needle and inject some local anesthetic. There's a little bit of local anesthetic, and they automatically will find the nerve. It's not that you really need to sit on top of the nerve. Okay? See the nerve in here. Okay? But now I'm going all the way down to the side. Then all of a sudden I see several other things. Yeah. Now, what do I see now? So I come from here, rectus muscle, and all of a sudden I see 3 layers. See that here? 3 layers. Obliquous superior, obliquous inferior, and this is the transversus. You know these muscles? Yeah, perfect. Perfect. Now, there's one interesting nerve in here. See that one here? So, obliquus externus, obliquus internus. This is the transversus. And between the internus and the transversus, I have this nerve. In fact, there are 2 nerves. There are one nerve that calls the ilioinguinal nerve. The other nerve is the iliohypogastric. What is happening? The iliohypogastric nerve comes all the way from the back and goes this direction. Go back all the way here. That's that one. The ilioinguinal comes from the back and goes a little bit further down and goes into the inguinal canal. Okay, so if you have inguinal surgery, this is a very good pain block. Understand? Inguinal block for inguinal surgery. Iliohypogastric block for lower abdomen surgery. Okay, you need to know your anatomy. That's the problem. You need to know very well what is happening. So, you see here, see the 3 layers here, 3 layers of the muscles. Yeah, and there it is. Okay, it's not really essential that you hit the nerve. No, make sure that you're in between those 2 layers, and the local anesthetic will find the nerve anyway. Understand? So useful blocked nerves here. Yeah, if you need median surgery, stay with the rectus abdominis muscle. If you have lateral surgery, inguinal surgery, the inguinal nerve. Yeah? If you have lower abdomen, then is the iliohypogastric. Understand? Okay, so that's that. If there's any question, please let me know. Huh? Now I need to show the femoral nerve. So perhaps you can take this. Oh. Okay. Now, important nerves for the lower extremities are the femoral nerve, the obturator nerve, and the lateral cutaneous nerve. I just show it here, this side. So make sure that the legs are positioned almost exactly as you had it, like this. A little bit like in a frog like. Okay. So we have the femoral nerve sitting here, goes all the way down, and that innervates the median portion of the leg. The obturator nerve comes more on the lateral, on the medial side, and goes to the inner side of your knee. Okay, and then we have the lateral one, the fascia lata on the lateral side. Okay, that is what we call sometimes the 3-in-1 block. But anyway, there are many variations of these blocks. Now we have the femoral nerve coming in the middle, and the first branch off is the saphenous. The saphenous nerve goes all the way down, yeah, till here, even till the heel of the patient. So it's one of the longest nerves that we have. The femoral nerve, first branch, is the saphenous nerve. Goes all the way down, just in front of your ankle, inner side ankle, and it's next to the vein. Next to the vein, so if you see the vein, you actually can see. Now, it's only a sensitive nerve. It has no motor effect, so you can't stimulate. Okay? The saphenous nerve, but you actually can find it if you look at the fascia of your tibia, and you go, yeah, just like this. It's always in front of that fascia of the tibia. So if I give a superficial block here, subcutaneous block, then it will cover that area. Then it will cover that area. So ankle surgery, inner ankle surgery, don't forget to do that block. It's very easy. You just need to have 5 milliliters of local anesthetics, go subcutaneously, and you always have the block ready. Okay? This is for the inner ankle block. Okay? But don't forget, it goes all the way down. From here, all the way on the medial side, goes down. Very long. Okay? The femoral nerve, because the femoral nerve branches off immediately. So I need to go up very high. If I go up high, I will see the femoral nerve. I will also see the femoral artery. If I go too low, then I will not see the femoral artery anymore. It will be branched off in several branches. I will not see the femoral nerve anymore, but I will see branches. That's more difficult. So what you need to do is you make sure that you find this point here, the spina iliaca superior anterior, that one here, all the way till the tuberculum pubicum, and that is your line. And in fact, that is the inguinal canal. Okay, the inguinal canal. So you need to make sure that you use your pen. Yeah, make a little bit of a mark over there, and that is where it is. And what is important that you know the anatomy. What comes more lateral? Artery, vein, nerve. I told you during my lecture. What was it? Need to know that. That's so important. Otherwise, you can't do this block. What is most lateral? Nerve. Okay. Nerve, artery, vein. Okay. And on this side, vein, artery, nerve. And don't forget that. Nerve, artery, vein, vein, artery, nerve. It's important because if you want to do a central venous line here, you need to know exactly where you are, that you're not going to poke into a nerve and to put in a central line. You understand? So it's very important. So be in that line, in the inguinal canal. That is where you need to do the plexus block, or the femoral nerve block. Don't go 3 centimeters below because you're lost. It's already branched off. That's very difficult. Okay, now I'm going to show you how to do the block. Okay. This. Again, your point is now on the medial side, because what I want to see, this is what I want to see here as well. Okay. Yeah. All good? So this is the spina iliaca anterior superior. See that? Everybody can feel that. That's the most of your pelvis. Okay? And we know this is the tuberculum pubicum. You go in the midline. So, see an artery already there. Need to be okay. See the artery. There's a vein. See the artery here. Okay. This is the plexus block, the femoral nerve. See, it's immediately to the lateral side. Okay, so the artery, the vein is over there. If I push hard, then it's collapsed, of course, but the artery is usually not collapsible. And this is the plexus. Now, what you need to do is come from that side, okay, all the way down. So from this side here, all the way down, and then make sure that you enter the plexus. So the femoral nerve, you come from that side and you come from here. So you need to bring it over here, over there, and there, but never too much medial. Understand? So it's very important that you stay in that vicinity, but you have to inject, because this is a big one. It's as big as your thumb. That is the plexus. It's a huge plexus. So make sure that you inject local anesthetics here, that you inject local anesthetics here and there, so that you have the complete nerve. Okay? So it requires quite a volume as well. Now I'm going down. Yeah. Yeah, I'm going down, and you immediately will see that. See that? So this is one artery. One artery. If I go down, now I have two arteries. That's already too low. Okay? Don't go that low because your block will not work. So it's important to stay high up, that you have one artery here and that you have the plexus over here. So the first branch off is the saphenous nerve. That's that. Okay? Now, if you want to do the obturatorius nerve, because the femoral nerve is good to do surgery in the middle of your leg. Okay? But if you have knee surgery, then you need to do more. Yeah, that's fine. Okay, now I need to go on the medial side. Medial side. Okay. Yeah. Okay. Pointer. Now, what do I see here? This is the adductor longus. This is the adductor brevis, and this will be the adductor minus. So these are the muscles on the medial side. Yeah, on the medial side, the upper side, that's the longus. Then we have the medius, and below is the adductor longus. Okay, so you need to understand the anatomy. Very important. Yeah. Longus, medius, and this is the minus. Now between the longus and the medius, you have the obturator superficial. And between the medius and the minus, you have the obturator profundus. So superficial and profundus. Okay, so if you have bladder surgery, it is important that you block these kind of nerves, especially for TURP operation, transurethral resection of the prostate. Understand? Well, then you need to do that. Okay? If you do knee surgery, on the medial side, that's also innervated by that obturator nerve. Okay? And you need to block this one. Okay, to summarize it a bit, because it's otherwise too complicated. You need to go to the femoral nerve for knee surgery. Medium size, that goes in the femoral nerve. Make sure that you feel the spina iliaca anterior superior. Okay? If you have to do also the medial size, then you need to go to the obturator nerve. If you have to do, for instance, the surgeon, urologist asked you to do TURP operations, and he is afraid of perforating the bladder, the wall of the bladder, and you do the upper one. Okay, that is what is needed. And we have also on this side now, this is the spina iliaca superior. Oops, sorry, the way. See that here? Okay, that's here. Now, if you go 2 centimeters to the medial side and 2 centimeters up, there you can block the fascia, the innervation for the lateral side, the fascia area. And that's sometimes very important because this fascia here, can be very painful, or they use it for transplantation surgery, burns, you name it. So if you want to do that here, then you go up spina iliaca superior 1 to 2 centimeters medial and 1 to 2 centimeters more cranial. You actually can feel the fascia. Okay, so you go with your needle through the fat layer, then to the fascia, and just below the fascia, that is where your nerve is located. Okay, just a couple of millimeters, and that's enough to block this whole area. Okay, now what else can we do? We can go in the middle. Yeah, we can go in the middle. Okay, again, make sure that your point is on the medial side. Now I'm looking again at the artery. There it is. See, it's not that difficult at the artery. Yeah. And you know that the saphenous nerve, that's the saphenous nerve. Okay, so I can block it here as well. So there are multiple options. Now this is very important because, and I forgot to tell you about another important nerve, and that sits here. It's here. I just forgot the lower arm. Oops. Okay, so I'm just in the middle of the lower arm. You see that here? And that's your median nerve. That's your median nerve. We have to do, for instance, an operation on the hand palm. Well, just block that median nerve. It's very easy. You easily can see it, and there's no artery in the neighborhood. So it's very easy to do that. Yeah? And if I come down, then you can follow it. You see that? You can follow it all the way down, and it becomes more and more superficial. Now I have a problem because he's using his lotion. Okay. Make sure that there's no jewels there. Okay, so I'm coming down. You see the median nerve? I'm coming down all the way towards the wrist, and then it becomes very difficult. How to distinguish that? So why doing a block here? Why it's so easy to do a block here? So look, I'm just putting it down, and I immediately can see my median nerve. Whereas if I do that here, it's very difficult. And why is it difficult? We have 9 tendons here, 9 tendons, have all our fingers and you name it, 9 tendons, and one of these structures is the nerve. But am I sure if this is the nerve or that or that? No. So don't do it here, do it in the middle of your forearm. That's much easier. Okay? But you can go to the side. There you can see, for instance, an artery. See the artery over there? Yeah. On the lateral side, that is your radial nerve. Radial nerve, there. Okay. It's a very tiny one. And on the medial side, sorry, yeah. On the medial side, you have the ulnar artery. And on the medial side of the ulnar artery, you have the ulnar nerve. So by knowing your anatomy, you can block virtually all these peripheral nerve blocks. You understand? Turn on the belly. Yeah. Yeah. Completely on your belly. The prone position. Prone. Okay. Okay. Yep. Yep. Okay. Make it, move it to the side. Move it to the side. Yeah, yeah. Okay. Yeah. Like that. Now it's good to know that you can do also a popliteal block. Especially for foot surgery, a popliteal block will be very useful. Also for ankle surgery. Now you need to know 5 nerves here. What are these nerves? Saphenous nerve, the tibial nerve, and the sural nerve. You know that? The saphenous nerve in front of the ankle. Posterior to the medial ankle is the tibial nerve. And posterior to the outer ankle is the sural nerve. The sural nerve comes from this part, the popliteal. Okay? So now it's possible to do sciatic blocks. Now, if you feel very carefully, I can distinguish between the biceps here and the semi-membranosus, semi-tendinosus. Again, I'm sorry I'm using all these anatomical names of the things, but you need to know very well anatomy if you want to do regional anesthesia. So you can divide the muscles. So this is the biceps, a very big one here. This is the semi-membranosus, semi-tendinosus. They go all the way till you're to this region, the popliteal region. Okay? And they make a triangle. In fact, if you see that here, can you hold it for a moment? Then I see. Can you see this muscle here? This tendon. This is the tendon of the semi-membranosus. Okay, from here. Semi-membranosus, semi-tendinosus. This other tendon, that's the biceps. See that? Now it's very important that you can feel it, because in the very obese patients, this will tell you where you exactly are, because otherwise you will be lost. Now, if I need to do a block, a popliteal block in here, I need to stay within those 2 tendons. So the semi-membranosus, semi-tendinosus on the medial side, the biceps on the lateral side. Okay? Now, again, yeah, if you, you have to keep it up a little bit. Yeah, you need good muscles. Huh? Okay, now, if you feel these 2 muscles, you stay in the midline, you actually can see immediately your sciatic nerve. Now, let me show where it is. You see it? There it is. Okay, so it's a big thing. Easy to be seen here on my screen. Yeah. It's a big thing here. It's as big as your thumb. Yeah, it goes all the way up. See it there? And it goes down as well. So you need to wiggle a little bit your transducer. Okay? Show it. But it's very easy. If you want to do a sciatic block, and it is possible, because patients have a broken leg or something, sometimes you can't put them in the prone position. You understand that? So again, what you need to do is oh, there it is. Yeah. Sorry. No, I'll take it. Okay. So what you do, you visualize it and you come from the lateral side. Okay? Come from the lateral side, and then you make sure that you block the sciatic nerve. That's very useful for lower limb surgery. Okay? So go in the middle from here to here. If you go up to more proximal, at a certain point of time, you have the gluteus muscle. The gluteus muscles will make it very difficult. It is still possible, but then you need a little bit more advanced in these regional anesthesia. But it is possible. I can show it to you, but anyway, that's where we want to do it. And then if you go down, all of a sudden you will see Okay, now I see an artery. See the artery over here? Okay, and a little bit deeper, yeah, you have the vein and the artery over there. Vein and the artery. It's easier to be seen on the monitor here. Okay, and that is where you can do a popliteal block. Now, popliteal block can be more difficult than doing it in here. So the mid-femoral nerve block, it's, the sciatic nerve is much easier, but you can do it. You can do it over there. Okay. Now, from here onwards, we have the sciatic nerve is now making a diversification. Yeah? We have the popliteal nerve and the peroneus communis. And the peroneus communis, okay, so it's going in the fibula head, just over the fibula head, and going all the way down like this. That is your peroneus communis, and it's going to innervate the bottom of your feet. Okay, so that's a good one. The other one, the tibial nerve, stays medial. Yeah, I'll show it on this side here. Stays medial, goes behind the inner ankle, and does the innervations on the front. Understand? So you need to know 5 nerves. 5 nerves: tibial nerve, saphenous nerve, sural nerve, and we have 2 more. Go back to your supine position. Okay, so so we have the peroneus going all the way, and that is going to do the basic part of your. Still working? Okay. So this is from here. Okay. So this is coming from this point here in the popliteal area over the femoral head. Sorry. Fibula head. That's what I was looking for. Over the fibula head, and then it diversifies. Okay. We have in front here, we have 2 places where you can block the nerve. Just between the 2 ankles, that's for the superficial nerve, and there's one, can I just take it off? And there's one deeper nerve in between the first toe and the second toe. In between, just go as high as possible. You can do, and that's the profunda nerve of the 2. So the tibial one here, just the 2 ankles in between. That's the superficial nerve. This is the profunda nerve. Okay? So for any surgery on this side, you block these 2. For any surgery this side, you need to block the back side. And for any surgery on the medial side, then you need to block just in front of the inner nerve. You need, this is the saphenous nerve. Goes all the way down, and especially towards the ankle. Achilles. Okay, well, I think I've overwhelmed you with anatomy, but it is important that you know these things. It's so easy to do an extra block here, and in fact, if you do it from here, yeah, so this is the inner ankle, this is your Achilles tendon. Just make a line between those 2 areas, and it's just in the middle, behind the artery, that you find the tibial nerve. So it's very easy. So I can feel his pulses. Okay, it's very easy to feel the pulses of most patients. Yeah? And just go a fraction behind it, just between this point and that point. So the inner ankle and the Achilles tendon. Just go a little bit behind it and do the local anesthetic in there. 5 mils will do. In fact, if you go, then from here, and you perforate it to the other side, you can block the sural nerve. Understand? You can do with one injection through the skin, you can do both nerves, the tibial one and the sural one. Then you have the whole area. Okay? But there are 5 important nerves. Don't forget the saphenous one. The saphenous is for your inner ankle. Good. Any questions?
It's quite a comprehensive anatomy learning for us again. Remind us successful block from the good step. Then from the audience, is there any questions? Maybe there's some questions on from your current practice. Is there, if you compare between the suprainguinal fascia iliacal block, the suprainguinal fascia block, and you compare it with Feng block,
Yeah.
block, combined with lateral femoral.
Now, you come to a very good point. Yeah, I've given you the basic anatomy and the basic ways to do blocks. Nowadays, in the last 10 years or so, we have the Peng block, the fascia block, etc. I didn't do anything of these things. It will come. The Peng block is a very good friend of mine from Toronto, Professor Peng, and yeah, that's certainly a very good one if you do need to do, for instance, hip surgery. Yeah? So, but I think we need to do that at the next phase, because you first need to know. Don't come out of this. You first need to know these basic. Anatomy. Yeah, reason anesthesia without knowledge of anatomy, very difficult, I guess. No, the Peng block is certainly a very good one. Yeah, but I've done all kinds of blocks. Yeah, with the lumbar plexus block combined with sciatic nerve blocks, you name it. It's all possible. So there's not one place in the body where there's no coverage of different nerves. And that helps us to be able to do blocks, whereas others will take a completely other approach. That's possible, yeah. Yeah, but that's well, if you have the school here, yeah, the Bali, the Denpasar school, yeah, and you have learned all together a specific block, then you are very proficient in that block. And you have to learn a new block, or they introduce a new block. It's not always as efficient because we have vast knowledge and experience of doing your own block. You understand? So introducing a new block and immediately comparing it, it takes a couple of years to make sure that you do both techniques, and then you say, okay, we are proficient in both techniques. Let's now do a comparative study and compare the results. That's only fair. But if you introduce a new technique with an established technique, that's not really correct.
Maybe from the audience, okay? Is there any more questions? Maybe, sir, thank you very much for all the participation from the audience and also participation online, whether offline also, through all the questions, all the discussion is very meaningful for us. We're very grateful for our speakers and also for our committee and the facilitators for sharing this beautiful insight today. So we hope to find next years for another lectures and all about our discussion for the next discussion for us. All the lectures and all the topics and workshop are very both informative and inspiring for our clinical practice. Wishing everyone for a safe journey for all the medical journey in our practice. And we look forward for seeing
Thank you very much for having me today and for allowing me to talk to you and explain a few of my experiences. I always want to share my knowledge, and for that reason, you can, well, use all my books or whatever publication you can find. There's always a little bit of what I want to try to do is all the time is, of course, there's theory, but I always want to illustrate it. That was my drive, why I started with videolaryngoscopy or videolaryngeal mask. I want to visualize that area. That's why I started. You see a few of my posters here. I can't recall when exactly I made them, but I think 20 years ago. I wanted to make a structured approach so that people can understand, okay, do this. If it doesn't work, do the next step, etc. So that you have practical guidelines, that you have practical things, but that you actually can see. Thanks to this kind of machines, we see the anatomy. I can teach anatomy like this, yeah, in a couple of hours. Now, obviously, I've only restricted to a few blocks. We can do much more than that. But you see at least an idea that by visualizing, you can do a lot of things. Yeah? By visualizing these nerves, you can block a lot. And that's very good because patients will suffer less if they have no pain. You understand? That's my drive. I want to share my knowledge. I want to show that visualization in anesthesia is very important. And I even got an award in the Netherlands for visualization in anesthesia. So I gave a full lecture. Yeah, that was the Professor Vermeulen Kranch Award, which is the highest award in the Netherlands. And that was given to me. She was the first professor of anesthesia in the Netherlands. I happened to know her, although she was late 80s or 90s or so. I happened to know her, so a fantastic lady. She came from the United Kingdom and was the first professor of anesthesia in the Netherlands. But anyway, they give now the highest award in her honor. Thank you very much and enjoy the rest of your day.
Professors, before we end today's guest lecture, we would like to hand over a token of gratitude, a Balinese authentic souvenir. For the committee, please take a picture. You professors, our heartfelt gratitude to professors for the amazing lecture, and I hope we all find insights to improve our clinical practice in the future. Thank you, Prof. Semuanya bisa maju ke depan, kita ambil foto. Yuk teman-teman residen ada di koas bisa maju ke depan, kita ambil foto bersama.